into the meeting. And in the interest of time, I want to go ahead and get started. Thank you, everyone, for taking the time to be with us today, and welcome to the third annual Cancer Wellness Symposium, co-hosted by LifeOmic and Karuna Precision Wellness Center. I'm Jamie Renbarger, and I'm the founder and wellness director of Karuna Precision. And I'm just thrilled to be here today, partnering with Don Brown and LifeOmic to bring today's keynote speakers to you, all who are well known in their fields and have really contributed to advancing research and patient care in this space of cancer wellness. Dr. Wayne Jonas, Dr. William Lee, and Dr. Jonathan Stegall. And again, I'm here right now with Dr. Don Brown to kick things off. So first, just a couple of housekeeping things. There will be a 5-minute break at the end of each presentation so that you can have a few minutes to step away from your computer and do whatever you need to do. And second, we'll be taking questions throughout the day. And you can place those in the Q&A box at the bottom of your screen, and we'll address those at the end of each session. And then finally, we'll be sending you a short survey after the symposium, and would appreciate any feedback. Our goal is to continue to refine and improve this based on what all of you want to hear. So in addition, you'll receive a recording of today's presentations for future reference. So with that, again, my name is Jamie Renbarger. I'm a pediatric oncologist by training, have worked on faculty at Indiana University School of Medicine over the last 20 years, really looking at ways and focused on optimizing care for individual patients with cancer and their families. And that's really evolved over time to now my having a really strong commitment to long-term health and wellness in people impacted by cancer. So Karuna Precision really was born out of that vision and has really allowed me the opportunity to collaborate and continue to work more and more closely with LifeOmic. I'm thrilled to be here today to tell you a little bit about some of the work we do together with Don Brown. Don is LifeOmic's founder and CEO. Don is hands down the most successful serial entrepreneur, software entrepreneur in the Midwest, and having created and sold several highly successful tech companies. Don is also a technology and business advisor, investor, philanthropist, and LifeOmic really is sort of the I think penultimate venture for Don, in my opinion, throughout his career. And it really brings technology together with precision health in an innovative cloud and mobile software platform. And we're going to kick off today by telling you a little bit about what we do and then leading into a few presentations from there. So with that, I am going to share my screen. And all right, perfect. Go back to the beginning. All right, so what we're gonna again talk a bit about today is just to kick things off is Karuna, LifeOmic, and the work that we do there, and how that supports oncology care for all the way from cancer prevention to survivorship. So the focus again today is on cancer wellness. We do a lot within LifeOmic focused on precision oncology within the setting of relapsed cancer. That's not the emphasis of this particular presentation, but is something both Don and I are super passionate about and would be happy to have more in-depth conversations with anyone about in the future. So this slide really, to kick things off, shares information that I think probably most everyone on this call is familiar with, and that is that cancer is really the story of great success. With improved treatments over the last decades, the death rate from cancer has continued to decrease particularly rapidly since the early 90s. And that has translated to about 500,000 cancer survivors in the state of Indiana, where I'm sitting today, and over 20 million cancer survivors across the United States. So that's the good news. The bad news is the process of cancer, the inflammation associated with cancer, and the treatments that we use can have a profound and lasting impact on the individuals impacted. And this circle slide on the right, or circle figure on the right, really just summarizes some of the most common complaints, if you will, or challenges faced by people impacted by cancer. And so, I started my career really focused on a very narrow piece of this, and that is chemotherapy-induced peripheral neuropathy, and really found that my passion expanded to the whole person during and after cancer treatment, and really finding ways to best help people get back to life. And Karuna and the center that we developed here in Indianapolis really was born out of that. And so our mission is to establish, or has been to establish, a center providing outstanding, integrated, personalized services focused on people impacted by cancer, and really getting them back to life. And our long-term vision is to improve health and wellness, long-term health and wellness for individuals with cancer or a history of cancer across the United States and beyond through innovative care, research, and education. We do that, and Karuna's been an interesting journey, launching a nonprofit in the middle of a global pandemic, and so we have pivoted and really provide a lot of services, and all of the services, the vast majority of those virtually, but we take a very client-centered, individualized approach in focusing on not only physical functioning and physical wellness, but also nutritional wellness and cognitive, psychosocial, and emotional wellness, and providing a personalized care plan that's delivered one-on-one to the individual client, again, aimed at helping people live their lives to the fullest. And I think what I've learned both through my academic role, as well as through this more wellness-focused emphasis over the last few years, is that engagement is critical. People need to be engaged and empowered to support themselves, to change habits, and to live their healthiest possible lives. They need to be empowered and responsible for that. We focus both at Karuna and at LifeOmic on some key pillars of health and wellness that are summarized here, from eating healthy plants to increasing and maintaining physical activity, taking time for mindfulness, getting quality sleep, and time-restricted eating. And with that, I'm going to pass the baton to Don to talk a bit about LifeOmic and how this all fits together.
Thanks, Jamie. I just want to say it's an honor to be associated with Karuna and Jamie, the tremendous work that they've done. Certainly survivorship, I think, is kind of a somewhat overlooked area of cancer care. So what we do at LifeOmic is really try to provide a data platform. There's all sorts of information now that we can get about cancer and cancer patients. And it's really important for cancer researchers as well as oncologists to be able to aggregate this information. And this slide just illustrates the simple fact that patients aren't in the hospital, thankfully, all the time, that many cancer patients live their lives 99% outside of a healthcare system. And so that's why it's important to be able to collect data from them about other facets of their life, whether it's their activity during exercise, how they're eating, all these other places and times that we spend outside of a healthcare system. So if you want to go on to the next one, Jamie. So what we have done at LifeOmic, we've spent about 5 years working initially with the Indiana University School of Medicine to build a cloud-based data platform that can collect all these different types of information. Everything from the genetics of the cancer itself, the genetics of the patient outside of the cancer, and then data that comes from wearable devices and other sources, including a mobile app that we've developed that really spans across this entire continuum. And so it provides a number of benefits. We can analyze that data along with researchers and community oncologists. We can engage patients, which is critical in order to be able to collect that information in the first place. And that can come in the form of our mobile app or the many sorts of wireless devices, rings and watches that many of us wear, and other data sources, including clinical tests that might have been run. And then that allows clinicians to intervene, to spot problems early, to be able to coach cancer patients and survivors through the activities that and eating patterns that might be most beneficial to them. And so probably the biggest thing that we've worked with Jamie and Karuna to do is to try to provide content that is meaningful to cancer patients and survivors so that we can help them through that process. Obviously, getting the cancer diagnosis is just a huge punch in the gut. And we want to be there to help people better understand, deal with the diagnosis, and optimize their treatment and recovery. And for us, it all begins with the data. We've got to have a place to aggregate this data to understand the cancer. And thankfully, more and more these days, once we do have that understanding, there are things we can do and increasingly precision therapies that we can offer.
Yeah. And this is really, just to continue on with that, this has really, I think, been a key part of my role as I've started to do more work together with Don and LifeOmic, and that is coming at this from the oncologist perspective to really have a good understanding and develop tools to help in engaging patients. And so at LifeOmic, our goal, while we started with precision oncology and the setting of relapse disease, our goal is to really engage with and guide patients across their cancer journey, starting with a 4-week foundational oncology program, which really allows the cancer care team to interface with patients to provide some key information to really help in empowering them and successfully launching them on this challenging journey. All right. I'm learning a lot. I've never hosted a meeting like this before, so I'm learning a lot about the parts and pieces that I'm deriving all at one time. Key with LifeOmic is that LifeOmic really I look at as a software system that has a lot of opportunities, a lot of Legos, if you will, that we can bring together to support patients and to optimize wellness. So including things like collecting survey information on everything from pain to depression and other things, providing information through really engaging courses, and then supporting individuals, supporting patients to develop and maintain healthy habits, even in the midst of what can be a really challenging journey. And this is all delivered through a mobile app. And so the foundational oncology program that we introduced on the last slide is, again, a way to engage with patients throughout their cancer journey using a digital app. As Don mentioned in his first slide, our goal is to really move this even earlier in the scope of someone's life towards prevention. And so another key area of focus for us is not only in preventing cancer, but preventing chronic illness across the whole spectrum of chronic diseases. And so to that end, at LifeOmic, we've developed a 12-month program called LifeAscent that provides not only educational content, but also very simple to-dos to really support individuals in developing healthy habits to help in preventing diseases like cancer. So again, this is another tool that's has been developed and is delivered via mobile app. Unlike other kind of wellness programs that are out there, it really is completely evidence-based and includes interacting with participants, consumers, patients, through collection of things like blood biomarker tests and other surveys, as well as delivery of a success kit to allow people to continue to track their progress over time using a variety of objective tools. LifeAscent is available out there. If you go to the app store on your phone, whether you have an Android or an iPhone, you can find LifeOmic, LifeExtend, and LifeAscent is delivered through this mobile app called LifeExtend. The content is actually broken down by body system, and again, supports individuals to develop healthy habits over time. The structure is broken down in each 4-week block to provide content, so some foundational learning, to allow an individual to assess their risk for developing something like cancer in the Cancer Prevention Month, which I lead, to then act on that risk and to develop a plan focused on disease prevention. And this is just an example of the screen from the Cancer Prevention Month, showing how content is delivered in a really simple daily to-do. Each day includes a motivational quote and things like guided meditations or very specific activities, as well as educational content, like you can see here, to really help people, support people in developing healthy habits based on knowledge. And with that, I think we will, if there are any burning questions, I'm not seeing anything in the chat, and I'm gonna, like I said, bear with me as I stop sharing. All right, perfect. Looks like maybe, yes, perfect. So in the chat is the link to the website for anyone who's interested in learning a bit more. Again, this is something I'm incredibly passionate about, as is Don, and we would be happy to talk more with anyone about it anytime. So thanks, Don, for
my pleasure.
Yeah, and with that, now I have the distinct honor of introducing you to Dr. Wayne Jonas. Wayne, Dr. Jonas, is a practicing family physician and someone who I've had the distinct honor of getting to know through some collaborative work that we've done over the last year or so. He's an expert in integrative health and healthcare delivery, who's published widely in this area. Dr. Jonas is Executive Director of the Integrative Health Programs at the Samueli Foundation, which is an effort supported by Henry and Susan Samueli to increase awareness of and access to integrative health. Dr. Jonas is also retired Lieutenant Colonel in the Medical Corps of the U.S. Army. And from 2001 to 2016, he was president and CEO of the Samueli Institute, a nonprofit medical research organization supporting scientific investigation of the healing process in areas of stress, pain, and resilience. Dr. Jonas was the director of the Office of Alternative Medicine at the NIH from 95 to 99. And prior to that, he served as director of the Medical Research Fellowship at the Walter Reed Army Institute of Research. He's a fellow of the American Academy of Family Physicians, and he's led and participated in hundreds of research studies, beginning with his time as director of the NIH Office of Alternative Medicine. While serving as CEO and president of the nonprofit research organization, the Samueli Institute, his work really set the bar for evidence-based research in the areas of pain, stress, and human performance. He's the author of a book called How Healing Works, and his research has appeared in peer-reviewed journals such as the Journal of the American Medical Association, Nature Medicine, and just to name a couple. He received the 2015 Pioneer Award from the Integrative Healthcare Symposium, the 2007 America's Top Family Doctors Award, and 2003 Pioneer Award from the American Holistic Medical Association. With that, I want to thank Dr. Jonas for joining us today to share some of his great work. Thanks, Wayne.
So thank you very much, Jamie. It's a great pleasure to be here. I appreciate the invitation to come and speak at the Karuna Wellness Symposium. What a tremendous program that you have there, and what a tremendous need you have for both bringing together the good news about cancer care that you provided and integrating it with the bad news, which is we're really getting better at treating the cancer, but we're not very good at helping the person. And I haven't found a person yet with cancer who isn't also a person. And so I think this integration of cancer care and whole person care is essential, and that you're doing that at Karuna, and the work with LifeOmic that you just illustrated was fantastic in terms of making that easier to happen. So you said everything I wanted to say in your introduction, Jamie. So what I'm going to do here is what I'd like to do for your audience is widen the lens a little bit. Let's see now. Host only. Okay, I need sharing opportunities here, because my share is not both needs to go and is going, or at least is trying to go. And it needs places like yours in order to show it the way, to be leaders in these areas, so that the kind of care that you just described is routine and regular, which is our goal here at the Samueli Foundation. So I want to talk about this term healing, and I'm going to talk a little bit about how you do that in COVID. I don't think we're quite out of COVID yet, and it has had a huge impact on how care is delivered, some good, some bad. And so I'm going to talk a little bit about how that has reinforced the need. So what I'd like to do in the next 30 to 40 minutes here is help you understand where health actually comes from. You'll be surprised. It does not come from going to your doctor's office. Maybe that won't surprise many on this symposium. I'll identify 4 dimensions of whole person care, which really pretty much give you the gamut of what most people need for the management of health, for the improvement of chronic disease, for prevention, for optimal cancer therapy, and some of the evidence to support that. In order to make this easier, we've created something called the Hope Note Toolkit. I'll describe that on how to apply it and some of our work with you, the cancer community, and LifeOmic in that area. And then I hope when you leave today on Monday, you'll have a number of new skills. One of which is that you'll be able to see whole people more quickly. What is a whole person, and how can I listen to them, hear them, detect them, and begin to work with a whole person, not a part of them? That if you're a provider, you'll know how to remain a healer in the midst of medicine, and if you're a patient, how you'll know how to become your own healer. I'll show you how you access some of these tools I mentioned, the personal health inventory and the Hope Note, and that if you're a system leader or if you run healthcare, you can begin to make the changes in your system in which the nation is attempting to go. So the fundamental question that's already been pointed to here that we need to be asking ourselves every single day if we're providers and patients is, how do we integrate healing and curing? Now, this seems like a strange question, except that our health system, as it currently done, focuses almost entirely on curing through treatment of the disease by asking what's the matter with you, and then putting you into a framework to treat that disease. And in the process, we have forgotten about healing, which deals with the person, which starts with the question of what matters to them in life, not just about their health, but why are they here on earth, and helping them to become whole people in those areas. So it is this integration that we're fundamentally talking about. Now, if you work in a healthcare system or run one, this question translates into the following: how do we get from healthcare, medical care, to actually creating health and well-being, which I'll show you it is not doing. And so we need to be able to make that transition in our systems. Let me introduce or give you an example of this. I like to anchor things in real people and what happens with them. So this is a real patient that I've had, and this is not her real name, but she had platinum level health insurance and access. So she worked for the military, for the DoD, where she had access to any kind of healthcare, medication, treatment, specialist, behavioral health, primary care that was needed. She was on her way to do her job, the Pentagon, and she had a car accident, which then resulted in the development of low back pain. She didn't break anything, but she developed some dysfunction in her lower back and some disc problems in her lower back that produced persistent pain and difficulty in functioning. And she got on what an individual with good healthcare access does. She ended up getting on the pill and procedure treadmill, and over a period of about 10 years, ended up on multiple pain medications, including opioids, muscle relaxants, got injections and surgery, then sleep medications, sleep handouts, and antidepressant medications in those areas. And this was the state of her when she came in to see me. Now, here was Cynthia's team, and I put this in quotes because they were not actually acting as a team. That is, they weren't working in concert. She would come in and see each of these individuals individually, and they would give her an assessment and a plan and a recommendation of things to do, and then send her on her merry way. Very rarely did they communicate with each other, except for a medical record that was usually inadequate. And so she had seen all of these individuals over those 10 years. And during that time, she actually became so disabled that she had to quit her job, something that was really important to her in defense of the nation. Now, Cynthia was also on opioids, and you may recall there was an epidemic that occurred before the pandemic that you heard about constantly. Every state in the union and 2 presidential commissions were held to look at the opioid epidemic, which is emerging out of the chronic pain problems that we have. Opioid prescriptions went up tremendously in the last couple decades, and the deaths did too. Before the pandemic, there were 60,000 deaths from opioid overdoses every year in the country. And now in 2020 and 21, that has increased to 93,000 in 2021 and over 100,000 in 2021. So the situation has gotten significantly worse. Many organizations have come out with guidelines, the American College of Physicians, the Joint Commission, the FDA, the Department of Defense, the VA, saying, let's not use for chronic pain so many drugs, especially opioids, and move towards proven evidence-based approaches, non-pharmacological approaches that have been shown to effectively treat pain. Now, had we been listening to patients for the last 30 years, we would have known that they were already trying to do that. They just called it something else. They called it complementary and integrative medicine or alternative medicine. And these are the kinds of things that were often used: therapeutic massage, yoga, acupuncture, manipulation, mind-body practices. But the evidence for each of these, which had been lacking in the past, is now sufficient for those national bodies to say, these now are evidence-based guidelines, begin to use these approaches. However, I and the system that I was trained and work in never knew how to deliver these kinds of approaches, nor did we get paid for it. Fortunately, Cynthia had access to a healthcare system, the military healthcare system, as I mentioned, in which I work. And so she was able to get an integrative or a whole person care visit. And that visit started by asking Cynthia what mattered to her, not what was the matter. And she said, family is most important, and I would like to get back to work. This was one of her life's goals because she loved her work. She had multiple problems that were supporting her chronic pain issues and preventing her well-being and her function. Her sleep issues were atrocious. She needed some support on that. When I asked her what did she did for self-care, she said, well, I get in a hot tub, which I bought in the morning, and I stretch and stretch. And I said, this sounds sort of like yoga. And she said, oh yeah, I went to one of those yoga classes, and the woman was folded up into a pretzel in the front, and I tried that and I hurt myself. Yoga does not work. Cynthia had not gotten appropriate guidance for therapeutic yoga, that is evidence-based yoga, but she was trying to do it on her own. But Cynthia needed assistance in behavioral change, not a counselor that would put her on another medication, but a health coach. She needed mental health support, but when she came in to see me, the very first thing she said is that I'm not crazy and I'm not addicted, I'm in pain. She did not want to go to see a counselor. She did not want to go down the mental health route, but she needed support for her social and emotional body. She also needed some non-pharmacological approaches, so-called integrative medicine, such as acupuncture, physical therapy. So once we got this organized in Cynthia's life and got the team organized that included herself, the health coach, the group, the other members of the healthcare team, and her family, we had her go to see a professional therapeutic yoga practitioner who knew how to deal with chronic back pain. And she began to see that practitioner, and she'd only been there once or twice, and she called me up and she said, my pain is down. I never realized that without being in the hot tub, or on medications, it could be down. So she had the experience of her own healing potential and healing capacity, and that was the turning point. It still took several months of support, but she was on a path towards improved health and well-being. And within about 6 months, her pain levels were consistently down to 2, and she said, I'm going to start looking for a job, going back to what was meaningful and purposeful in her life, her mental and spiritual reason for being here. This kind of approach is a new type of care. This is not the kind of care you get when you walk into your average doctor's office, even if you have good health insurance. What you get is the conventional medicine illustrated in the top circle here on this slide. But what Cynthia was getting is what I call integrative health. And that was the merger of conventional medicine. We can't abandon that. It's very important, with non-drug approaches and self-care, the behavioral and lifestyle approach. And we call this integrative health, which is the model that needs to occur and that is occurring in Karuna and other places. Now, this applies in cancer too. There's a quote from Michael Lerner from many decades ago. It still applies where he says cancer is not always experienced as the greatest problem facing the person with cancer. Indeed, as people survive cancer more and more, it becomes less of the issue. And even if a person is facing an acute treatment on the cancer, it is still done within the context of their life and their family. And so when a person gets a cancer diagnosis, we have the collision of these two worlds. The provider's world with the oncology team, all focused on trying to kill the cells, remove them, get rid of them, et cetera, and managing the entire industry and delivery system to do that. And that then runs headlong into the patient's team, which has a number of other concerns, as you can see listed on the left-hand side of the slide, from family, from friends, sleep, hair, skin, other kinds of approaches like acupuncture that the oncology team may not know about, and many of the behavioral changes for improved wellness, as you see listed out in the bottom. So this collision overwhelms both sides. The oncology team is already overwhelmed. The patient is overwhelmed just by the system, and now we get information and management overload in the cancer setting. So to manage this, we need to reorganize how we do cancer care along the lines of what Cynthia got for her pain and opioid addiction. We need conventional medicine to treat the cancer for sure. We need non-drug approaches, and we need self-care into integrative cancer care, or oncology, or sometimes whole person care. And this is the direction in which cancer care now needs to go. If we do not do that, we will continue to get the problems that we currently have within our healthcare system. And this illustrates what some of those problems are. And this was all before COVID, okay? First, we are first by far in the costs and spending on healthcare, almost double any other group in the country. We are 37th in almost any aggregate outcome measure by the World Health Organization compared to other countries. We may end up spending 20% of our gross national product by 2025 on healthcare. And because of these things, the disparities, the difference between the haves and the have-nots are growing. There is widespread dissatisfaction in what you get when you engage the healthcare system, and those working in the healthcare system are burning out in droves. 20% have left since the pandemic in those areas, and it was already a problem before the pandemic came. This graph illustrates the lack of value we're now getting from the way we are paying for and the types of services we're providing in healthcare. This is graphing the life expectancy of a country over the total expenditure per person. And as you can see, the US is a major outlier. We spend double almost any other country in healthcare, and yet our life expectancy is somewhere around the level of Portugal or Czechoslovakia that spend significantly less. We know the reasons for this. Many data sets have looked at where health comes from. And they have shown that if everyone had universal platinum level healthcare insurance like Cynthia had, it would only improve the population's health by between 15 and 20%. And that has become because health comes from outside of those settings, mostly from the behavioral and lifestyle components that I've mentioned, and increasingly from the social and the economic factors that impede an individual from engaging in healthy access and behavior. And so if we want a healthcare system that produces health, we have to redesign our system so that it just doesn't focus on the top black area in this little graph, but actually helps to address these other health-producing factors. Now along came a little thing you may have heard of, the SARS-CoV-2 virus, producing the COVID-19 pandemic, in which we are now entering the third year. Hopefully the worst is behind us, but the devastation is not. In fact, COVID had a major impact on all aspects of our country and the healthcare industry, as well as health. in this area. In primary care, for example, close to 25% of individuals had to close or had people leave or could not find individuals to deliver that kind of care. Family decision makers found increasing mental health problems, more obesity, addiction, and disparities. And healthcare executives found that if they couldn't tap into the resources needed to save themselves, they had to close their systems, and most quality improvement efforts went on hold during the pandemic effort. When it's over, it's not over. We now have a multi-million person problem with what's called long COVID or persistent COVID in these areas. And in addition, when we look back and see who died from COVID and continues to be at risk, it was the same people with chronic diseases that our system had not been improving their health with very effectively. The elderly, those with multiple chronic diseases, including cancer, Blacks, Hispanics, Native Americans, people of color, those without good health care, and those in service jobs that could not socially isolate. The impact on life expectancy has been huge. Within the last 2 years, the life expectancy in the country has dropped at least by 2 years. Last figures I heard from the CDC, it's probably 3 to 4 years in the country over that single period, and it has dropped 3 to 4 times that rate in people of color. This is a emergency and a consequence of the COVID epidemic. The symptoms persist, as I've mentioned. 1/3 to 1/2 of post-COVID patients, whether they were hospitalized or sick or not, end up having significant symptoms 20 to 60 days later, and they're at increased risk of dying for the next several years after that. So it doesn't actually go away. It affects every single organ in the body. There's no one specialty that can address COVID or post-COVID issues because it affects the brain, it affects respiratory system, kidneys, blood. There has not been a system in which it has not been shown to be effective. The impact on cancer care has also been profound. It's been shown that during the pandemic, screenings to try to detect early cancers, which are a crucial way of managing it, have dropped by between 56 and 85%. Utilization of cancer care has also dropped by a huge amount. For example, mastectomies were reduced during that period of time, as were colonoscopies and others. The data shows that these delays and decreases will have and will increase cancer deaths and poor quality of life for years to come. The requirement then is the same before cancer. It's the same, before COVID, it's the same after COVID. It's the same whether you have cancer or don't have cancer. That is, we need a whole person approach. We can no longer divide the individual up into parts and say, well, I'll treat your disease, but I'll ignore the rest of you. This requires culture change. No one person, no one group can make this happen because it's going to require a system change that shifts towards whole person care. So what can we do to make that system change happen? I'll show you some things both in 3 areas, becoming more aware of this, and the nation is becoming more aware of this. Some action items, very concrete things that you all can do on Monday when you get home, and how accountability for these systems needs to be tracked in those areas. The most important and the most difficult is our mindset, seeing and communicating whole person care differently. We have a system built not to do that. It's built to divide the person up, treat parts of them and ignore the rest of them. So we need to cultivate skills to look at the person before they become a patient, or even if they are a patient, is to step back, not see them as a patient, but as a person. Cultivating skills of listening, changing the language to person-centered, relationship-based care. This is a mindset change. The mechanical mindset works fantastic if you need your life saved, you need a tumor removed, you need an infectious disease treated, you get in an accident, you're having a heart attack. We would not want to give that up. That is acute care thinking, and it works for those things, and it can save your life. However, for chronic illness, for prevention, for health, for well-being, for recovery, it does not work, as I've just illustrated. For that, we need an ecological mindset, a whole person mindset that addresses not just the body, but the behavior, the social and emotional part of an individual, and the spiritual and mental component. We need to shift and evolve our care models from integrative health, which I've just introduced you to something that is truly whole person care. And the integrative and complementary and non-drug approaches cannot be delivered somewhere over in the corner or in a particular center somewhere else. The activities that are going on at Karuna need to be at the heart of the cancer centers around the country and other healthcare centers. And to do this, we have to look at the whole person. The whole person actually is not all that complicated. Maslow showed many years ago what an individual needs to thrive, regardless of who they are or where they are in the world. And this model here illustrates a reorganization of that hierarchy in a way that can be delivered and addressed when you care for the person within a healthcare system. It takes a few questions from the body and the external component. It asks you about your behavior and your lifestyle. Number two, it addresses social and emotional issues because everybody has social and emotional issues, and it addresses the spiritual and the mental component. What matters to you in life? What brings you joy? And from that, then it creates a personalized healing plan. There are multiple organizations attempting to do that, and not surprising, it's the ones who have already pay for whole person care, like the military. I've worked for many years in the military. I still see patients like Cynthia there. And the military has created a model illustrated here called Total Force Fitness that they are using as the framework for implementing care of all of their members in those areas. When you get out of the military and are a veteran, there is also a whole person care model within the Veterans Health Administration. Here's their framework. It's called Whole Health. And it starts with what matters, the person in the middle, and then looks at empowering them around the underlying determinants of health that I illustrated to you before. Primary care has also got on board with this. Advanced primary care now goes beyond simply standard care, as you see in the middle here with the diagnosis, treatment, and payment, to more comprehensive quality primary care, to enhanced coordination of care. And then advanced primary care brings in integrative care, the non-drug approaches, and assisting people with the social needs if they have those in those areas. A national blueprint for high quality primary care came out from the National Academy of Sciences and Medicine a couple years ago. And as you can see from this definition extracted from that report, primary care is whole person, integrated, accessible, and equitable care. And as they point out in the introduction, we need to pay for primary care teams to care for people, not just doctors to deliver treatments in those areas. We have been working, and Karuna and others for the last couple years on bringing this kind of care into the care of cancer patients. We are doing it through something called the Integrative Oncology Leadership Collaborative. And this is a group of cancer centers around the country, top cancer centers that want to move towards and are moving towards whole person cancer care. They have a blueprint for that, actually. The Institute of Medicine back in 2013 actually talked about delivering high quality cancer care and incorporated many of these principles that we've been talking about. We use some tools to help engage and empower the patient and then look to make sure they have access to self-care support, supportive services, and that the guidelines, of which there are many for cancer care, are implemented within routine care. And that's what the IOLC is currently engaged in. CMS, Medicare and Medicaid, the government's payment system, has also said we need to do more of this, and they've created several approaches for doing that. The latest one is the Enhancing Oncology Care model. It's based on the National Academy's blueprint and a pilot work that they did called the Oncology Care model that just ended. And it's designed how best to place patients at the center of the care. They focused in on chemotherapy times for 7 cancers, as you can see, and they have now started to align it with the new cancer moonshot, which has also used these same terms and concepts in those areas. As of June 30th, there's been $215 million on the way to over $1 billion invested in the goals of the moonshot that focus on precision medicine and cancer research to reduce cancer death rates, improve quality of life of those with cancer, and advance health equity, prevention, and control. They're now delivering 86 grants through 3 different organizations. You can see them listed there, and let's hope they provide the kind of whole person care and support that we've been talking about. To do this, you have to actually pay for it. You can't nickel and dime and say, well, you can get paid for this part, but you can't get that part. You can have yoga, but you can't have nutrition education. You can have acupuncture, but you can't have counseling in those areas. The fee-for-service approach does not work for developing this whole person cancer care. And so our foundation and others have supported a series of workshops and a report in the National Academy of Medicine called Financing That Rewards Better Health and Well-Being. That will be coming out at the beginning of next year, and it will talk about how the money flow needs to shift so that we get away from simply the quantity of care, do more of this, to the quality of care, do more for the person. Well, if we do in fact see differently, how can then we do healthcare differently? To do that, we need to redesign the way we deliver care. We cannot do it within the current structure, and we need to build new tools, teams, and technologies that allow us to do that. Here's an example of such a redesign. This was originally developed for the Veterans Administration, but now is published in JAMA Health Forum a few months ago for delivery outside of those systems in civilian care. And what it does is it takes the medical side that we saw on the right-hand side that asks, what's the matter? And it merges it with the person side, what matters to the patient. And then it provides support services to allow these things to come together in a personal healing plan. This framing changes the mindset to one that is person-centered, relationship-based, and recovery-focused. It addresses what matters. It brings a team of healthcare partners to support the patient. It organizes a suite of recovery and wellness services that then are available and accessible, and it pays for it using value-based care, which is the kind of care for whole person that's needed. In addition, we've created, along with the IOLC and others, a set of tools. Healing needs its own tools, teams, techniques, and technologies. Otherwise, we cannot, in fact, deliver healing with the tools that we have. In the medical area, for those of you who are in the medical area, you're familiar with something called the SOAP note. That stands for Subjective Objective Assessment and Plan. And what it does is it's the way of making the disease diagnosis. It asks the patient what's the matter. It comes up with a diagnosis and a CTP code and then a treatment plan. It's what Cynthia was getting for the 10 years before she walked through our door to provide integrative care. It's materialistic for the most part and reductionistic. It tends to neglect social and emotional, mental health issues, and the spiritual component because it focuses mostly on the body or a physical approach into those areas. For those of you who are not aware, when you walk into your doctor's office, you are immediately put into a soapbox because he or she is thinking, how can I structure my note in the electronic medical record to describe everything that happens there. For healing, we need a new tool. It's called the HOPE Note. That stands for Healing-Oriented Practices and Environments. And what it does is it simply asks questions differently and about the things that produce health and healing. It starts by asking what matters to the patient. That's a mental and a spiritual question, as you see in the center of this person model here. Why do you want health? What gives you joy? And how can we align our health delivery and support to make that happen? You saw that with Cynthia and her desire to go back to work. It then also asks about social and emotional components because everybody needs those areas in order to change their behavior and lifestyle and see their own healing capacity. It then does talk about behavior and lifestyle, and then finally looks at the external environment and body to see what's needed in order to facilitate that process. Cynthia, for example, needed to find a place where she could do therapeutic yoga at home. She actually didn't have a place where she could do it routinely. So we had to arrange and help her arrange for an external process to do that. So we have built to deliver this a whole set of tools. We call it the Hope Note Healthcare Toolkit. It involves 4 major components. Number 1 is a personal health inventory that the patient fills out at the beginning, and then a guide for actually doing an integrative health visit using the Hope Note questions. And out of that then comes the personalized healing plan that we discussed. There is a whole set of resources available for healing that then are available for both the patient and the provider to tap into in order to accelerate the healing journey. Those tools support the very kinds of things you've already seen here in the introduction and will see more of as you go through today's symposium, starting with what matters, but then going and looking at these core behavioral and lifestyle components and social components that we know and the evidence supports facilitate health and well-being. These resources are organized into a clickable website in which once the patient identifies the key areas along with the provider that are needed, they can then access these at their fingertips. And I'm glad to say that we're also working, as I'll show you in a minute, with LifeOmic to streamline this, make it even easier so that everybody can do it. So finally, what can you, if you're a provider or if you're a patient, do in these areas? Well, if you're a provider or if you run a system, you need to demonstrate that how you reorganize things for healthcare delivery of the whole person actually is delivering on value. You need to engage the administration, the practice improvement teams, and you need to pilot, test, improve these areas using some of the outcomes I'll show you. What are those outcomes? Well, several decades ago, the Institute for Healthcare Improvement, which is the nation's leader in healthcare improvement and change, came up with something called the triple aim. It meant better outcomes, lower cost per person, and improved patient experience. And that's been the driver for many years. However, as burnout, that is clinician burnout, got worse, they've added an additional aim, improved clinical experience for the quadruple aim. Now with COVID accelerating disparities and the difference between the haves and have-nots and going the opposite direction of equity, an additional goal has been added, and that is equity. And that is the reduction in healthcare disparities, now combined with the others called the quintuple aim. And so if you are a healthcare leader, if you've got a clinic or you've got a hospital, then these are your key outcomes that we're trying to improve. We've just done an analysis of whole person care approaches around the country to see what kind of impact those things can have on the business case of various systems. That report is available at this link and at my website that summarizes some of those. I won't go into the details of that report. You can get it, you can read it, it's completely free, but let me show you a couple examples. The VA system, as I mentioned, has something called whole health, and they've now evaluated this over the period of the last 2 or 3 years. And they found in individuals like Cynthia, significant reductions in opioids and improvements in pain. The perceptions of care with whole health have improved. There's more engagement, which, as we pointed out, is essential for patients, and the overall well-being has improved, both for the patient side and on the provider side, which has shown more satisfaction and less turnover. It has also significantly reduced cost. In an analysis of over 130,000 veterans over a year, they showed that those who engaged with the whole health system dropped their costs by almost 20%, or close to $5,000 per person. If that was extrapolated to the country, there would be a savings of $1 trillion of costs avoided in those areas, thus requiring less money be put into our healthcare system. Here's another example. It's been going on for several decades up in Alaska, delivered by the South Central Foundation to the Native Alaskans, where they reframed their mindset and delivery system for whole person care. They don't call the individuals who come into the clinic patients. They call them customer owners, because they in fact do own part of the health system. And their outcomes by all quintuple aim metrics have steadily improved over the last 20 to 30 years, leading the way in terms of how we should redesign and deliver healthcare in a large system. In a survey recently of their system, they found that those who participated really pointed out that relationships was the key. And this has been shown with other data sets in those areas, that they had a relationship with their primary care physician, and the vast majority, 96%, were satisfied with their care and had input into care decisions. Equity has recently gotten back on the radar for healthcare delivery, and there's examples of how that happened. Here's one by a group called WellCare, in which they simply provided for one social need that might be identified when it was lacking for a patient, and that saved over $1,500 in healthcare costs. And if they provided or assisted in those people addressing all social need, they didn't have to pay for it, but they had to link them up with social services. They showed a 10% reduction in costs in those areas. So what can you do on Monday? You don't have to wait for policy. You don't have to redesign your healthcare system, but you do need to redesign your thinking. Well, first of all, keep doing standard of care. You don't want to abandon the treatment of disease. Very, very important. So do that. These are the care you already provide. But then add to that an integrative health visit using the tools I've shown you from the PHI and the Hope Note. Reframe the questions that address the underlying health and well-being determinants. There's many, many simple methods that can be added, such as acupuncture, mind, body, nutrition, safe supplements, etc. And there's a growing number of technologies that can assist in those areas. If you're in the position to redesign your health team, as I've just described, or train your individuals in health coaches, or do group visits, these can markedly enhance the delivery of this kind of care. Even if you don't have any of that, whether you're a provider or a patient, download the personal health inventory from my website and take it. It's a simple 2-page inventory that asks what matters to you, and then has you rate the areas of readiness for change that are the core drivers of health and healing. If, in fact, then you'd like to do an integrative health visit, all the resources are available again on my website. Ask your healthcare provider to do one of these. They can learn how to do it and get all the tools necessary to do it and the steps to do it there. And there is a series of resources for implementation that are growing, that have been produced both for primary care and increasingly for cancer care, that are also that. We are working with LifeOmic to actually streamline this even further in those areas. So stay tuned for that. If you have chronic pain, or if you're dealing with patients that have chronic pain and you're a provider or physician, go to this course. The Tufts School of Medicine has provided a free 4 hours of CME showing how you do integrative health chronic pain care. These resources are all available, so we can start, and you can start now. We don't have to wait for policies to change, although as I've shown you, they are trying to do that. We don't have to wait until your system changes, although as I've shown you, many of them are doing that, and Karuna is a great example. In fact, but the most powerful way to transform healthcare is to simply fill your medical bag with tools for healing, not just treatment, and integrate those in the care of the whole person. So again, I want to thank you for having me, and congratulations on the great work that you're all doing in these areas. And I'm happy to take any questions or engage in discussion.
Thanks, Wayne. All right. I'm not sure if you can see the Q&A. There are a couple of questions in the Q&A if you want
Sure.
to take a look at those.
So how do you feel about SBAR documenting? So I use acronyms, but I'm not familiar with that acronym. So you'll have to tell me what SBAR means for you. And then I'll try to get back to that question. So the second question is, I'm curious how whole health approaches differ in other countries. Is the higher life expectancy and lower spending outside the US due to better behavioral and lifestyle choices, or more implementation of whole health principles? That is a wonderful question. And this has been looked at actually across countries to try to understand why outcomes in other countries and costs in other countries are so much better than ours. And a lot of it does have to do with the support of the underlying determinants of health. For example, social and economic supports are there. The basic supports for behavior, lifestyle, access to healthcare is available in almost every other civilized country in the world because they have universal healthcare coverage, which we do not have in those areas. And there's a significant improvement in home care in many of those countries, in mental health care in many of those countries, and in the social and public health services in many of those countries. And when you have a healthcare system that's structured that way, then it can be flexible and it can identify the personal needs and then be precise, personalized healthcare for the care of the individual without having to worry, well, can I get it paid for? And if I can't get it paid for, I can't actually do it. And so, you know, other countries have delivered in these areas. Doesn't mean they can't improve in those areas. But thank you for answering that question. And we should look outside the United States. Doesn't mean we have to replicate what's going on in all the other countries, because there are great innovative models here in the US that aren't government sponsored. They're private. Even for-profit ones that are delivering really good quality care. And so the US can find its own mechanisms and models to do it, but the basic principles are the same across those areas. So SBAR then is from the first question is a kind of SOAP note, but more comprehensive. Yes, situation, background, assessment, and recommendations. That's what you meant by SBAR. Yes, I have seen that. I'm familiar with it. I think that's going in the same direction that we're trying to do with the HOPE and do this. So I think that's a great idea. What my experience has been is that the key and the thing that the HOPE note is trying to do, it's trying to bring in the things that we routinely do not address, that are at the center of most healing drivers, the 80%. That's outside the medical profession in those areas. So SBAR is going in that direction. I've not done a head-to-head comparison between that and the HOPE note in those areas, but I think that's exactly what needs to happen. Most of the HOPE efforts are brought into chronic care. You have here that SBAR is to help providers within hospital settings. That's great. But the HOPE note is meant for things like primary care, outpatient cancer care in those areas, which is actually where most of the day-to-day recurrent interaction occurs. So thank you for that question.
Okay. Any other questions, comments? Looks like
Thank you
one
for the
more
comment.
So we don't know if you see there was one added. Will my primary care physician take exception to my taking him your personal health inventory?
Try it out. If he's open to whole person care, he won't. If he looks it over and sees what it is, if he goes and looks at all the tools that are available, then if he actually is there to provide good whole primary care, which is what primary care is all supposed to be all about, right? Then hopefully he'll embrace it and say, "Oh, good. Here's some things that I can use that I didn't have before to do that." And you're right. You mentioned that your healthcare system does not seem to be focused on prevention and whole person care. You're right. You're absolutely right. Most systems, even if they're using the language of whole person care, actually are not sure how to deliver it. And so what we're trying to do with these tools is actually make it easier to deliver so that it becomes routine and regular. And we've had many providers who have taken those tools and just done it themselves, DIY, we call it, do it yourself, that now are implementing this on their own because they're available. And we hope the LifeOmics app will make that even easier. That is focused specifically on cancer care. And as I said, the IOLC is focused on making this happen in cancer care. A lot of the enlightened cancer care systems are going in the direction I showed you, a number of them that are trying to do that. One of the models is to bring a primary care team or primary care physician into the oncology setting and make them part of the oncology team to deal with these other aspects of this. So that's an approach too. But the oncologists, I think, need to be involved. They don't need to provide all that kind of care, but they need to be the leader of the orchestra of the team, et cetera, then to tap into the others who have expertise on these components and make them available.
Great. Okay. I'm not seeing any other questions pop up in the Q&A at this moment. So with that, Wayne, Jonas, thank you so much. It's always great to hear you speak and just to see the passion for the work that you do just emanate from you, and just grateful that you had the time to join us today. So thank you so much.
Well, thank you very much. And thank you for what you're doing there and for the cancer community at large.
Yeah. All right.
Okay.
All right. So with that, we have a short break scheduled in. We'll actually break for a little less than 10 minutes. We'll reconvene at 12:55 for our next presentation on the doctor-patient relationship. All right, so see y'all in a few minutes. Okay, everyone, welcome back from our break. So I want to take this opportunity to briefly reintroduce myself for those of you that are joined after the very beginning of the symposium today. My name is Jamie Renbarger, and I am your host today, and I'm also the founder and wellness director of Karuna Precision Wellness Center, a nonprofit in Indianapolis, Indiana, providing lifestyle and complementary therapies to cancer patients and survivors. Today's symposium is hosted by both Karuna Precision Wellness Center and LifeOmic. And I'm happy to connect with anyone participating in the webinar at any point in the future who would like to learn more about the work that we do, both at Karuna and or at LifeOmic. And with that, I want to move on and introduce our next speaker. Dr. Jonathan Stegall is founder and medical director of the Center for Advanced Medicine in Alpharetta, Georgia. Dr. Stegall has a true passion for providing the best care for his patients. He practices integrative oncology, which involves combining the best modern medicine together with natural therapies. And this form of cancer treatment, Dr. Stegall believes, should be safe, effective, and tailored to each patient's specific and unique needs. As a result of his specialized approach to medicine and his compassionate personality, patients travel from throughout the country to be under his care. He received a bachelor's degree from Clemson University, graduating with honors, as well as a master's in physiology from Georgetown. And prior to starting medical school, he conducted research on the doctor-patient relationship at Harvard Medical School. After earning his medical degree from Medical University of South Carolina, he completed his postgraduate training through Yale University School of Medicine, with clinical training at Greenwich Hospital and Yale New Haven Hospital. And during this time, he conducted rotations in integrative oncology and began developing his own unique approach to cancer treatment. Dr. Stegall went on to complete a fellowship in integrative oncology through the Metabolic Medical Institute, which is affiliated with the University of South Florida, Morsani College of Medicine. And in addition to his clinical work, Dr. Stegall is a best-selling author. His book, Cancer Secrets: An Integrative Oncologist, reveals how you can defeat cancer using the best of modern medicine and alternative therapies, provides a must-have guide for cancer patients and their families. He's the host of the podcast Cancer Secrets, which is an award-winning podcast with worldwide audience. And he's also creator of Cancer Secrets University, a comprehensive online course for cancer patients and their families. Dr. Stegall is a member of the American Society of Clinical Oncology, as well as the Society for Integrative Oncology. And with that, I'm going to pass the baton over to Jonathan Stegall. Thank you so much for taking the time to be here today.
Oh, thank you, Dr. Renbarger. It's an honor to be here. I'm very familiar with your work and the work at Karuna Precision Wellness, and also our sponsor, LifeOmic. I'm very familiar with the fasting app. I'm a big believer in fasting, and so I'm very familiar with the work you're doing, and I'm honored to be here. So thank you.
Sorry, hopefully you can share screen and just share slides directly.
Yes, I can. Let me make sure we're working correctly here. Let's see.
All right.
How is that? Can you see that okay?
Yes, that looks great. That looks great. If you want to go into, yep, perfect.
Okay, excellent. Well, again, thank you for having me. I'm so honored to be here and really talk about a topic that's really important to me. It's the doctor-patient relationship, as you mentioned. I think it's such a sacred bond between doctor and patient, and we'll talk about kind of the history of that. But if I'm being honest, I'm a little discouraged about that doctor-patient relationship today. In our healthcare system, in our world, I feel like it's strained. And so part of what I want to talk about today is kind of how we got here in terms of where we are in healthcare with the doctor-patient relationship. talk about why it's important, talk about some of the studies surrounding that, and then talk about how we can fix it, because I think we have some work to do. So I'm excited to share this topic I'm so passionate about with everyone today. So a little bit about me. Again, thank you for that great introduction, but I am an integrative oncologist. I have my own practice in the Atlanta, Georgia area. So that's my full-time job. And so sort of getting to that point, you know, I kind of was reflecting earlier on my experiences in my life that kind of got me here. And really the first big event in my life related to cancer was my grandmother. She was diagnosed with stage 4 stomach cancer when I was 5 years old, and she and I were really close. And, you know, we did a lot of stuff together. She lived not too far from me. And so, you know, I remember when she was diagnosed and my mom explaining to me that grandma has cancer, and she explained, you know, a tumor and that's a growth. And she mentioned that grandma was going to have some pretty aggressive treatments. And so she explained to me chemotherapy and radiation and things like that. And so she explained, you know, that grandma's going to, you know, probably be sick. She's going to lose her hair. She's going to lose some weight. And so I was prepared to kind of see, you know, what would happen, you know, through my 5-year-old eyes. But I remember, you know, things like when my mom took grandma to buy a wig, you know, she bought me a wig. It was a clown wig, of course. It was a fun wig for my age. But I just remember all those little details. I remember her going for chemotherapy treatments, radiation therapy treatments. And unfortunately, you know, even though she went through all of that, the treatments didn't work. And so she did pass away. But I remember even at the age of 5, just being very aware of how that whole process changed my grandma. You know, she was a very positive, happy person. But I really saw cancer just really kind of rob her of a lot of her peace and joy. And I was very aware of that even at my age. And so I didn't know what kind of an impact that had on me at the time. But certainly as I got older and was considering, you know, my future and figuring out what I'm supposed to do with my life, I thought back about that experience because it really was meaningful to me. And then the other sort of big key for me was my mom. You know, she was a family doctor, but she was very integrative in her approach. And so, you know, I grew up with, you know, good nutrition and supplementation and the importance of exercise and managing stress and all those things way before it was popular. I mean, it was not even as popular then as it is now. So I was that kid who, you know, had friends over to my house and mom would say, here, take some supplements. They'd be like, why are you taking vitamins and stuff? So I kind of grew up with that though, and a real appreciation for it as well. Just a huge respect for that approach to healthcare. And I saw my mom get amazing results with patients. And so when I decided to go to medical school, I knew I wanted to be integrative in my philosophy. So those are kind of the two big things that really led me to medical school and into oncology. And then as I went through my medical school rotations, you know, I just found that I was just drawn to cancer patients, and that was not something that I forced. It was not something I had, you know, kind of planned on. I just found myself really gravitating toward those patients. I mean, I enjoyed talking with them. Obviously, medically, I didn't feel that I could help them a whole lot, especially at that point when I was still learning. But I would find myself going back to spend time with them after I had done rounds and my work shifts and stuff. And so I just really enjoyed connecting with them on that personal level. And there was one patient in particular in medical school. I remember I was on one of my 3rd-year rotations. We, you know, rotate through all the different specialties, and I was on my internal medicine rotation. And he was one of the first patients I had on that service. And he was from about 2 hours away. He had driven himself I was working at the VA hospital at the time, treating veterans, and he'd driven from a couple hours away. He parked his car in the parking lot and he said, I'm here for a few days to get some radiation for my colon cancer, and I'm going back home. And he was in his 60s. He was divorced. He had a couple of adult children. But I really got to know him because I realized he didn't have anybody there with him. And so I felt like he was kind of lonely. So I would go hang out with him and talk to him, you know, again, after my shift was over. And I got to know him really well. And you know, I saw him really decline quickly. I mean, he started having a lot of complications from his cancer and from his radiation treatment. and he passed away kind of unexpectedly. I mean, he was obviously declining. I knew he wasn't doing well, but his death really hit me hard, and I'll never forget that. But I just remembered the impact that made on me, and I thought there's just got to be alternatives for somebody like this. There's got to be something else beyond just conventional, cancer treatment. And then the other big significant issue for me was memory for me was in my residency training. I was working on the oncology floor, and I was taking care of a young lady who was about 30 years old, and she had actually had cancer about 10 years prior, and had successfully had that treated in remission, and then her cancer. She had another cancer pop up as a result of the radiation she had as a secondary cancer. And so I remember she was just so full of life. She was a teacher. She just kind of had to put her life on pause because she was in the hospital a lot. And I saw her decline as well. And it turns out one of the nurses that was taking care of that patient with me ultimately became my wife. She's a nurse practitioner. And so we were actually taking care of cancer patients together. And we on one of our first dates, I vividly remember my wife saying, there's got to be a better way to treat cancer. We're seeing this young lady that's our age just die from this. And so those situations all kind of culminated, along with others, of course, into me really making it my life's mission to improve the way we treat cancer and to get better outcomes for patients. And so that, beyond, residency and fellowship and all those things, I knew I wanted to kind of start my own practice. And so that's what I do now. And I opened my practice about 8 years ago, as I said, in the Atlanta area. So that's kind of the framework for who I am. But at some point along the way, I really did realize that my interest in medicine wasn't the science. It was really just the meaningful relationships, connecting with patients and their families, and really partnering to try to get a better outcome. So today we're going to cover some important topics. We're going to talk about the history of doctoring. I think that's really important to get a good foundation for medicine and the role of the doctor in medicine. And obviously I'm going to use the words like doctor and physician, but certainly these days that's going to apply as well to others on the healthcare team, whether it be a nurse practitioner, a physician assistant, anyone in a leadership role with a patient. This absolutely applies to you. So I'm not trying to leave anyone out. I'm just going to talk to you about it from my perspective as a physician. We'll talk about the standard of care in healthcare today, what that means and how it's kind of come to be. We'll talk about the doctor-patient encounter today. We'll talk about some key components of the doctor-patient relationship. We'll talk about research into the doctor-patient relationship and how it actually affects treatment outcomes. And then we'll talk about how a strong doctor-patient bond fits into an integrative cancer treatment program. So a brief history of doctoring. When we think about doctors, we think about Hippocrates. Every single physician in the United States, and I believe around most of the world, recites the Hippocratic Oath, and that's part of becoming a doctor. And that was actually written around the 5th century BC. And I wanted to highlight a few of the key lines from that oath. It's a very long oath. You can Google it if you want to read the whole thing. I didn't want to bore you with the whole thing during our talk today, during our limited time together. But a few of the lines I really liked. I will apply for the benefit of the sick all measures that are required. I will remember that there is an art to medicine as well as a science. Warmth, sympathy, understanding may outweigh the surgeon's knife or the chemist's drug. I will not be ashamed to say I don't know. I will remember that I do not treat a fever or a cancerous growth, but a sick human being. And I will prevent disease whenever I can, for prevention is preferable to cure. And I think those are all just really important things to keep in mind, because this is the foundation for what doctoring is supposed to be. So since the time of Hippocrates, there have been a lot of different views on medicine and how to treat it. If we look at the idea of formal medical education, it was around the 9th century AD when the first known medical school opened. That was in southern Italy. And then for several centuries after that, the theory of humors is what really dominated medicine. And so humors are bodily fluids linked to disease. The humors are blood, phlegm, black bile, and yellow bile. And an excess or shortage of any of these four humors was believed to be the cause of disease. And so the treatment was really dictated by which of these humors was out of balance. And so if there was too much blood, then bloodletting was the treatment of choice. If too much phlegm was identified, then an expectorant would be given and things like that. So that was really the main way medicine was approached for a long time. And then even with this rudimentary knowledge and understanding of medical science in the Middle Ages, there was still a keen awareness of environment and how important that can be. And I think that's interesting because I feel like for a long time we moved away from the importance of environment, and we just kind of focused on, okay, the patient's body and whatever drugs or surgery we could apply to that. But centuries ago, they were talking about air quality, they're talking about climate, even the elevation where people lived was considered important. They talked about food, hydration, the importance of good nourishment. They talked about exercise, the importance of sleep. These things were valued, and I think we've lost some of that. We're just now starting to kind of get a renewed importance with those things. Then the 17th century, the Age of Enlightenment, ushered in an area of more scientific rigor. So this is a time when there were a lot of different professions that practiced some form of medicine. There certainly were doctors and nurses and midwives, but barbers had some role to play in medicine, herbalists, and there were certainly charlatans then, just as there are now as well. So a lot of different people sort of had a role to play in medicine and healthcare at the time. And then in the 18th century, we started what would be considered the modern era of medicine. And during this time period, anesthesia was developed. The germ theory was proposed to better explain the causes of infection. And they actually identified what are called miasmas, foul odors, as what they believed was the cause of illness. So it was also around this time, unfortunately, when women were largely pushed away from medicine. It was a very male-dominated field, still is, but certainly we've seen a really good shift in recent years to more women in healthcare. But just for some history, Elizabeth Blackwell was actually the first woman physician in the United States. That was in 1847. But it wasn't until the 1970s when women were more commonly seen being accepted to medical schools in the United States. And as we all know, over the past 50 years, medical science has just exploded. And when it comes to cancer, our understanding of cancer and what it is and how to treat it has just really grown immensely. We've learned so much more about it. Chemotherapy was introduced, 40s and 50s. So since then, we've obviously learned a lot. And so when we talk about sort of the main treatments today, most of us are familiar with those: chemotherapy, radiation therapy, and surgery. Those are really the mainstays of cancer treatment today. Immunotherapy is another treatment category that's really become a major component for the treatment of cancer, a lot of cancers at least, over the past 15 or 20 years. And so science has allowed us to develop these wonderful treatments, but I also feel that there's a significant downside. And the downside when we rely so much on not only science, but on just certain areas of science, is that we can be tempted to make science our God rather than our guide. And I think that's a really important distinction. We need science, we have to have it. But there's a lot more that needs to go into choosing treatments and a treatment plan for patients than just what science of this very moment is telling us. So when we talk about the standard of care, we're talking about the main treatments that we use today. And when we talk about cancer, we're talking about chemotherapy, surgery, radiation therapy. And the standard of care really is developed because research has shown that those treatments work. They have an anti-cancer effect on some level. And as we know, research is typically funded by a drug company or a device company, and they want to benefit in some way. That they basically are hoping that this new treatment under study will prove to be effective, and then it will therefore become part of the standard of care. So not surprisingly, these companies are spending significant amounts of money on the preliminary research, the clinical trials, even, you know, if the trials are successful, the marketing of these treatments. So again, the goal is for these treatments to become the standard of care. And so when we look at the healthcare systems in the United States and around the world, we know that virtually all physicians are practicing based on this standard of care. So when we think about our healthcare system, at least in the United States, we know that it's considered by many to be the best in the world. We have incredible scientific advancement. We have a consensus from all the leading medical authorities regarding which treatments should be applied to each disease. And on the surface, this sounds great, right? But unfortunately, the standard of care is limiting. And I say that because there are a lot of treatments outside of the standard of care. And I've certainly seen this in oncology, and I'm aware that this is the case in other specialties as well. There's treatments outside the standard of care, which still have a lot of really good scientific research behind them to support some sort of activity that we find beneficial. It's just that the research is less significant than the research for the standard of care treatments. And so my problem with that is, you know, these treatments are often sort of deemed useless or ineffective, or they're really heavily criticized to the point of being called dangerous. And I think that's unfortunate. So we're going to talk more about that later, but just keep that in mind as we kind of talk about the standard of care. So talking more about the standard of care, it's typically what insurance, Medicare, Medicaid, all of the big payers for healthcare are going to cover. So that's why all that research is so important, because that's what insurance companies will then say, okay, well, there's enough research for this. We're going to cover it, some or all of it, depending on the patient's insurance coverage. And when we think about healthcare providers today, you know, as a group, we're at the mercy of these payers. And that really is dictating the way medicine is practiced today. There was one survey, a national survey done a few years ago, and they found that 89% of doctors no longer feel that they have adequate influence in the healthcare decisions of their patients. 89%, that's 9 out of 10. And the same study found that 87% of doctors said that health insurers interfere with their ability to prescribe individualized treatments. So doctors are frustrated that they feel like they don't have as much of a voice in how that patient in front of them is being cared for. So when we talk about the doctor-patient encounter today, you know, insurance, Medicare, and Medicaid, they not only reimburse for specific treatments, they also reimburse based on time spent with patients. So providers that go over the allotted time are not going to get paid more for that consultation. So when we look at actually the time spent with patients in the primary care setting, so internal medicine, family medicine, pediatrics, the average time a doctor spends with a patient is about 15 minutes. That's it. And when we look at oncology, it's not a whole lot better. About 38% of oncologists spend between 17 and 24 minutes with patients, and 27% of oncologists spend between 13 and 16 minutes with a patient in a consultation. So from 13 to 24 minutes to talk about life and death, to talk about a disease as serious as cancer, I think that's pretty sad. That's really not enough time, but that's the reality today. And interestingly, when we look at training, you know, the problem seems to start early in training. First year doctors, so these are recent medical school graduates. They're in their first year of training. We call that the internship, the first year of residency. They spend almost 90% of their time in the hospital away from patients. So this is a setting where there are tons of patients. A lot of patients need to be seen, they need to be cared for. You know, these first year doctors are the front line basically to take care of these sick patients, but only 10% of their time is actually spent with patients. You know, the rest of the time is spent doing all kinds of other things that are necessary and required today. And I think that's sad as well. You don't get enough patient time. And it's important to note as well that the federal government funds graduate medical education in the United States. So residencies and fellowships is funded by the United States government. So they spend about $12 billion a year on graduate medical education. So it's a lot of money that's pumped into funding newly minted doctors. So what are these young doctors spending their time on? Well, research has shown that about 28% of their time is spent on charting. So they're usually sitting in the computer these days. In the old days, it was pen and paper in a paper chart, but today it's on the computer. They're a third of their time almost is spent charting, documenting what they saw with a patient, what treatments they want to prescribe. 21% of the time is spent on hospital rounds. So they're going around the hospital as a team with a lead doctor and then these younger doctors and usually some medical students as well. 16% of their time is spent communicating with team members. 9% of the time is spent communicating with members who aren't part of the team. This may be social workers or a doctor outside the hospital or something like that. And then 7% of the time is spent on education. This is studying, noon conferences, things like that. So that's kind of how the time is divided. So as you can see, it's mostly not time spent with patients. And then of course, the time crunch continues outside the hospital as well. So the outpatient setting, the brick and mortar, outpatient practices where you probably go see your doctor, they're crunched for time as well. And again, we get back to the need for documentation. There's so many requirements now for documentation for what happens in a visit, that's really eating up a lot of time. One study found that for every patient encounter, and again, that's about 15 to 20 minutes on average, doctors are spending an additional 16 minutes charting in the medical record. So if you think about let's say a doctor sees patients for 8 hours a day, well, 7 or 8 more hours is going to be spent on charting, about half the time. So that's a lot of time spent charting. So if we think about it, the practice of medicine is being dictated by people who aren't in the exam room with patients and who often aren't even healthcare providers themselves. And so there's a lot of frustration and resentment on the part of healthcare providers today. One recent study found that over 50% of physicians have experienced symptoms of burnout. So physician burnout is a real problem. And when we look at how that affects physicians themselves, we see increased rates of substance abuse. We see depression, suicidal thoughts, poor self-care, increased risk of motor vehicle crashes. When we look at the healthcare system as a whole, we see that physician productivity is reduced. We see that there's more physician turnover. They leave a job, they start a new one, or perhaps even leave medicine altogether. We see that patients have reduced access to care. If there are fewer physicians or fewer physicians who are able to effectively see patients, then access to care is reduced. And we see costs go up in these situations as well. And then from the patient perspective directly, they experience a lower quality of care. They are at a higher risk for more medical errors in their case, longer recovery times, and certainly not surprisingly, patient satisfaction is a lot lower as well. And so this is a big problem, all stemming from physician burnout. And there was another study on practicing physicians, and they found that 80% of physicians are at full capacity or even overextended with their panel of patients. So that basically means that they don't have any more time in their schedule to take on new patients. And so, again, where are patients supposed to go find a doctor? And it's a problem. 62% of doctors are pessimistic about the future of medicine. They don't feel good about where medicine is headed. 55% describe their morale as somewhat or very negative. 78% sometimes, often, or always experience feelings of burnout. 23% of physician time is spent on non-clinical paperwork. And I think that's probably on the low end based on some of the other research that's out there. 46% of practicing physicians plan to change career paths, almost half. 47% of physicians have their compensation tied directly to quality and value, but only 18% of them believe that quality and value payments will improve care or reduce costs. So they don't really believe in the system as it stands right now. And 49% would not recommend medicine as a career to their children. So 50%, 1 in 2 of doctors would not recommend that their kids go into medicine. I have young kids. My oldest son is 5, and he often says, "Daddy, I want to be a doctor like you. I want to be your assistant doctor when I grow up. I said, okay, buddy, that sounds great. And I would never discourage him from doing it, but I'll be honest, I would definitely make sure he understands what he's getting himself into, not only with the time spent, in training, but also the reality of healthcare today. And I hope by the time he gets there, it's going to be a lot better. I'm determined to make it so. But it's very sad to see these numbers. I mean, these are real numbers. This is a big study that I'm citing here. And I've got a significant number of colleagues who say I wouldn't do it if I had to do it all over again. I would do something besides medicine. And that's sad. It hasn't always been that way. So we need to just keep that in mind next time you see your doctor, that there's a very good chance that they're burned out, that they're frustrated, and they probably have some regrets. So the doctor-patient encounter today. So obviously doctors aren't the only ones who are frustrated. Patients are very frustrated as well. Research shows that patients are increasingly dissatisfied with the encounters with their healthcare providers. And one study found that dissatisfaction was most often related to poor bedside manner by doctors. So how does that doctor interact with the patient? How friendly are they? Do they listen? And we're going to get more into some of those details now. But I also want to mention that this isn't just a United States problem. This is a worldwide problem. There was one study that looked at healthcare in 23 different countries, and they found that 2/3 of patients feel disrespected by their physicians. 44% felt disrespected because their doctor didn't spend enough time with them. 33% felt disrespected because their doctor wasn't on time for appointments. And 25% felt disrespected because their doctor didn't answer questions. They didn't involve them in treatment decisions, and they didn't explain medical terms well. And one of the study authors summarized the findings in this way. It says, when we look across 23 countries, we see that only, I'm sorry, I can't see this part. Let me change this real fast so I can see. There we go. Let me go back to my screen here. Sorry, I'm trying to get back to full screen. Let me see how I can do that. That button is covered up for me. Let's see if I can move this. Here we go. There we go. Sorry, I couldn't read the right side of my screen there. The quote was, when we look across 23 countries, we see that only 3 in 10 patients rate the care they receive from their doctors as excellent, and less than half would recommend their physicians. I find this really sad. I'm guessing you do too. So let's talk about how we can fix it. So when we look at the doctor-patient relationship, there are 3 models, and we actually can go all the way back to the 1950s. There was a study in 1956, and this is one of the earliest pieces of research I could find on doctor-patient relationship, but they outlined 3 basic models of this relationship. So the first is the active-passive model. And in this model, the physician acts upon the patient. So the patient is basically treated like an inanimate object. The physician's in charge, the physician directs everything, tells the patient what to do. This is sort of the paternalistic model that we've all heard of. Secondly, we have the guidance cooperation model. And in this model, the physician has the knowledge. They decide what's in the best interest of the patient, and then the patient's expected to comply. And this is still a little bit paternalistic, but a little bit less so than the active-passive model. And then the mutual participation model, the physician and patient have an equal partnership. The physician is the medical expert, and the patient is the expert in his or her own life and goals. And so when I think about oncology today, I think we've moved out of the active-passive model, but I think we're still in the guidance cooperation model, and we need to get it all the way over to the mutual participation model. I think that's really where the sweet spot is, where both doctor and patient are most fulfilled and satisfied. So in my mind, there are some key components to this doctor-patient relationship. And so I think from the patient perspective, patients have to be vulnerable. They need to trust their doctor. They need to be willing to communicate goals and be willing to express concerns. And I'm going to go through each of these individually in just a moment. And from the doctor perspective, the doctor must be professional. They must be willing to listen. They must be open-minded. They need to clearly explain medical terms and medical jargon. And they need to provide recommendations, not directives. So let's dive into each of these. So starting with patient vulnerability. So if you look up a definition for vulnerability, it's defined as the state of being exposed to possibly being harmed, either physically or emotionally. So I'm not advocating for patients being harmed. I don't want patients being afraid or ashamed. When I speak of vulnerability, I'm referring to patients opening up, being honest, even about things that might be uncomfortable. And there's a good quote I like by Brene Brown. It says, vulnerability is the core, the heart, the center of meaningful human experiences. So vulnerability allows patients to be their authentic selves. They can let their guard down, let down their walls. And that really allows for a therapeutic bond to be formed. And I think this is important because, you know, we're all, especially in the age of social media, we're also tempted to kind of put on a false impression of who we are. We post the best pictures. We, you know, our lives look perfect to others, you know, on social media. And I think for a lot of people, that's even true when we go out in the world. But when we step inside that exam room, I think that needs to stop. We need to be vulnerable. We need to be honest. Sometimes that can be sharing raw emotions. It can be sharing fears, sharing major goals, whatever it may be. Patients deserve to have that with their doctor. And so being vulnerable, in being made to feel comfortable being vulnerable is obviously a big part of that. And that falls on the physician. And so I'll talk more about that later too. But patient vulnerability is important. And I think that's lacking today. So in order to be vulnerable, patients have to trust their doctor. And so when we look at trust and what patients base their trust in a doctor on, we can really boil it down to several things: competence, compassion, privacy and confidentiality, reliability, dependability, and communication. So basically the physician needs to be well-trained, they know what they're doing, but the physician also needs to be compassionate, understand the patient's situation and plight to some degree, need to do what they say they're going to do. They need to communicate things well, and then keep all of those things private and confidential between the doctor and the patient. So that's really what we're talking about when we talk about patient trust in their physician. So in addition to vulnerability, it's important to talk about goals. Patients need to be able to talk about their goals with their doctor. And these goals can be wide-ranging. They can be treatment goals. They can be goals for that specific visit. But really, I think that starts in that first initial encounter a patient has with their doctor. There needs to be some goal setting and sharing of sort of desires and ideals. And so research has found that this can be accomplished well with the use of questions. So patients can say, for example, my goal is to better understand my cancer diagnosis. Can you briefly explain to me what cancer is and how I got it? Another example, my goal is to incorporate good nutrition into my treatment plan. Do you have any advice for how I can best do that? Or my goal is to minimize side effects from cancer treatment. What can we be doing to decrease my risk of side effects? These are just some examples, but this is a good way to kind of get that conversation started. And then in addition to being vulnerable and sharing goals, patients also need to be comfortable sharing concerns. And I think a lot of patients are hesitant to do this because they don't want their doctor to think they're questioning them or insulting them. But I always tell patients, if you see something that doesn't make sense, always ask. And that's true whether it comes down to a part of your protocol. If there's something, you know, certainly safety related, you have a question about, please ask. Whatever it may be, always know that you can bring that up. We won't be insulted, we won't be offended, just please bring it up because we want to be able to talk about it. And always just remind patients, it's your body. You have a right to make sure that you understand everything being done to your body. So that's always number one. So in terms of the physician side, I mentioned earlier that physician professionalism is really important. One of the questions I often get is, does physician attire matter? I mean, you see me, I'm wearing a shirt and tie, a white coat. That's important to me, but the research actually backs that up. So they did, one group of researchers did a study involving thousands of patients, and they found that a majority rated physician attire as being very important to them. Formal attire, shirt and tie for male doctors was most highly rated. And then patients also talked about the importance of physician grooming in this study. They talked about the importance of clean clothes, no food stuck in their teeth, make sure their hair is combed, things like that. as being important. They equated that to not only competency, but also compassion and concern for the patient. But obviously it's not just about appearances, it's also about how doctors carry themselves. So research has talked about the importance of greeting patients warmly with a smile, a handshake or a hug when appropriate, looking patients in the eye, listening really intently. These are all things that have been rated really important to patients. And then of course that gets us into listening as well. There's a big disconnect between doctors thinking that they are good listeners and patients actually feeling listened to. So one survey of physicians found that a majority consider themselves good listeners. They think, yes, I'm a great listener. I listen to my patients really well. But then when we look at the research on the other side, only 36% of patients in primary care offices, at least, were given the opportunity to speak about why they were there for their visit. So typically when a patient walks in, the doctor will say, hi, Mrs. Jones, how are you today? What brings you in today? And it may be, I'm having headaches every day, or my blood pressure reading at home has been high, wherever it may be. But 36% of the time is all that happens. So the rest of the time, we're seeing doctors not even ask the patient while they're there. And when we talk about specialists, such as oncologists, that goes down to 20%. So only 1 time out of 5 are specialists, such as oncologists, asking a patient why they're there, how they're doing, things like that. And so when patients were asked for the reason for their visit, they were allowed to speak for only an average of 11 seconds before they were interrupted by the physician. So the rare occasions, again, between 20 and 36% of the time, depending on the kind of doctor they're seeing, where they even asked why they're there. And then when that happened, they were cut off after about 11 seconds. The doctor just didn't want to listen anymore and had to start talking. So physicians are not good listeners, even if they tell you that they are. So the next part of what I think needs to be done on the physician side of this doctor-patient relationship is having open-minded doctors. When I entered medical school, on our very first day, one of the doctors who was speaking to us said that roughly 2/3 of what we would be taught during our training would turn out to be wrong. 2/3. All the time spent studying and learning and memorizing, 66% is going to turn out to be wrong on average at some point in our career. That was a sobering thought, but I never forgot that. Because many physicians today are arrogant at what they know. And I think not only that, they're dismissive about what they don't know. And this is a dangerous combination. I think we're doing our patients a real disservice to discount tests and treatments that we don't know much about, and just assuming that they must be wrong or not important. I talk to my patients about articles and questions they bring into me all the time. Many times I'm familiar with it and we can talk about it right then, but there's times when I haven't heard of it and I need to look into it more, especially if it's something they found on a random site on the internet. And so it's good for the patient because they have a question about something and they need someone with medical knowledge to look into it for them. And it's been good for me because I can learn new things. If I'm being honest, I found some really great tests and treatments that I've used with patients as a result of patients bringing stuff into me. So this focus needs to be on being a lifelong learner and not just, okay, I've done my training and I go to a conference every year and that's all I need to know. Because there's so much out there, especially when it comes to oncology. And so we need to all be lifelong learners as physicians. So this next one is a biggie, and it involves medical jargon. Doctors need to do a better job of explaining medical terms to patients. One study looked at a number of doctor-patient encounters, and they found that 80% of the time, physicians used at least one medical term and didn't explain it. So doctors in this study used medical terms an average of 4 times per visit. So that average visit of 15 to 23 minutes, 4 times they were using medical terms and didn't explain them. So using clear language is really important. I know that we have our own language in medicine and we have to learn all these big words and abbreviations and acronyms and things, but we have to be careful that we're explaining it to patients in a level they can understand. Excuse me. So one strategy that's been proposed in the research is for physicians to ask patients to explain a concept back to them. So if a doctor is explaining, okay, this is the type of cancer that you have, and they spend a few minutes explaining that, ask the patient, okay, so I hope I explained that well. Do you mind giving me a recap of that? So that can be helpful. I think the risk with that, though, is we don't want patients to feel quizzed or put on the spot. So I don't use that one a lot, but that is something in the literature that has been proposed as a way to make sure the patient is confirming their understanding. Drawing pictures and diagrams is also another way that can help explain a topic, especially if patients are more visual than auditory. It's good to sometimes have a diagram or a picture or something. And in the very least, asking patients if they understand or if they have any questions, it's essential. And every consultation with, did I explain that okay? What questions do you have? I found that saying what questions do you have is better than saying, do you have any questions? Because again, we don't want patients to feel like they're stupid or that they don't want to, waste time. Asking them with the expectation that they're going to have questions, I've found kind of softens that a little bit. So what questions do you have is a good way to sort of to open the floor to them, and they can ask whatever questions based on what I didn't explain well or questions that we just didn't get to in the course of that consultation. And so finally, for physicians, I think this is important, provide recommendations and not directives. So again, moving more away from that paternalistic model of medicine where the doctor is the dictator or the authoritative figure and the patient has no rights or no say. I think physicians need to start by presenting their recommendations, because as a physician, we do have an important role to play. We are the expert, but we need to leave time for discussion, because our recommendation is not necessarily what that patient is going to choose to do. And so patients need time to ask questions. They need time to be able to discuss any alternative treatment options that they've read about. This is the time when patients can say, well, that's great, you're recommending chemotherapy, but I read about this herb from China that's supposed to cure cancer. Let's talk about that. Okay, let's talk about that, because that's something that's been important to them, and it's probably something, at least in their mind, they've been weighing as a viable option. So we can talk about whether that is or not. And so not only talking about different options from the patient perspective, but also the pros and cons of those. And I always make sure that patients know one option is to do nothing. Most patients don't choose that, but that is an option. Doing nothing is an option. And occasionally I've had patients say, you know what, I don't want to do anything. I want to go home and be comfortable and just kind of see how I do. And that's a valid choice. It may not be my recommendation, but it's my choice. It's their choice. So they need to know that. And then finally, it's essential that doctors practice collaborative medicine. So that's being collaborative with patients, but also with their families, because especially in oncology, families are very involved. A spouse, adult child, sometimes parents, depending on the age of the patient. And so, they need to feel part of those treatment discussions as well. Of course, making sure that the patient's okay with that, they has their permission. But I think being collaborative is important with the patient and their support team, but then also that extends to other healthcare providers as well. If a patient's seeing a surgeon or a radiation oncologist or a nutritionist, we need to have open lines of communication if possible. So that's something that we need to do a better job of as physicians. So what makes a good doctor? Research has sort of identified some key attributes, and I've touched on some of these already, but to kind of give you the list: professionalism, open-mindedness, compassion, attentiveness, self-improvement, empathy, calmness, adaptability, passion, confidence, and humility. Those have been identified in research as the key attributes of a good doctor. So ask yourself, your doctors, how many of these do they check off for you? If you're being honest, hopefully all of them, or at least most of them. But it's just a good checklist for you to think about with your doctors that are caring for you, for our patients out there. So let's talk more about how this doctor-patient relationship affects outcomes. We know it's important. We know that it improves patient satisfaction, but how does it actually affect treatment outcomes? Well, there was a study over 40 years ago, published in 1979. They looked at several hundred chronically ill patients, and these were all hospitalized patients. And they asked these patients if the doctor-patient relationship, they didn't ask patients, they asked the question of the study, does the doctor-patient relationship affect health outcomes? And what they found is the doctor's knowledge of the patient's health complaint heavily influenced the patient's perception of recovery. And so the doctor's knowledge of the patient's health complaint was improved when the patient initiated the consultation. So the patient took some sort of initiative to be there. Obviously in the hospital, patients don't always choose to be there, but this has been shown in the outpatient setting as well in the doctor's office. When patients voluntarily choose to go, their satisfaction is higher. And they actually tend to do better in terms of their complaint being resolved. So the real takeaway here to me is that doctors are going to subconsciously take patients more seriously when they're proactive about their own health. So a patient who comes in well-informed, well-researched, they want to be there, they're engaging, doctors are going to take that patient more seriously. And I think that's probably just human nature. I don't think it's intentional necessarily, but I do think it's pretty common throughout different specialties in healthcare that a patient that's more motivated and more proactive is going to be taken more seriously and therefore get better care and therefore probably get a better treatment outcome. So the authors of this study from 1979 did a follow-up study in the early 1990s, and they also included a lot more patients this time in this follow-up study. And they found that treatment outcomes were impacted by the quality of communication around 3 different areas. History taking, so how in-depth was that doctor in taking their medical history, understanding why they're there, et cetera. And then how well did the doctor explain the disease process? Do they explain in easy to understand terms? Was there jargon used or was it explained well? And then thirdly, outlining their treatment recommendations. They clearly explained what they're recommending and then gave the patient time for follow-up questions. So these things impacted whether the patient got resolution to their problem or not. And I think that's fascinating. I mean, on the surface, it sounds like common sense maybe, but I don't think we think about that a lot. But a doctor who's going to take more time with the patient, take a better history, explain things well, and then allow time for honest dialogue back and forth is going to have better results than a doctor who just rushes through and doesn't listen and hasn't reviewed the chart before the patient came in and interrupts and things like that. They're not going to have as much success. So communication is very important. And there was another study, there was a systematic review. So they basically pulled data from a lot of different types of studies. These were all good quality studies. There were 30 plus studies that they looked at in this systematic review. And they found that a good doctor-patient relationship has a positive impact on objective health parameters. When we talk about objective parameters, we're talking about lab results, imaging results. These are things that are very standardized and measurable. These weren't just subjective findings like my vision's better today or things like that. It's very measurable. I think that's fascinating. And research even has shown us that the doctor-patient bond affects patients' brains. They've actually looked at what are called functional MRIs. And so they can look at different areas of the brain that light up with varying types of encounters that patients have with doctors. And they found that the really good doctor-patient relationship actually affects the neurology in the brain. So I think that's fascinating. So this is a significant opportunity for us, especially in oncology, to consider a strong doctor-patient relationship as a tool in our toolbox to impact treatment outcomes. And I say that with all sincerity. This is an important tool. If we're doing a good job with our patients, obviously that includes the right treatments and all those things, but making sure that we have that good doctor-patient bond is going to affect outcomes. So in addition to actual clinical outcomes, I think it's also important to talk about patient satisfaction. And so when we look at the doctor-patient relationship in terms of satisfaction, obviously it's going to be higher when patients like their doctor. But another study found that patients' level of trust in their doctor determine their overall satisfaction. We have even more research that shows that the degree of warmth and compassion from that doctor shown to the patient was directly correlated with patient satisfaction. So I know we're running toward the end of my time here. I'm trying to make sure I get through everything, but I do want to briefly talk about the integrative cancer treatment model and how the doctor-patient relationship kind of fits into that. So for those of you who aren't familiar, integrative oncology is combining the best aspects of conventional medicine with sort of the best of natural or alternative medicine as well. So it's important to note that we do not abandon proven therapies such as surgery, chemotherapy, radiation therapy, immunotherapy. In my integrative practice, we use chemotherapy, immunotherapy all the time. So these are important treatments. I recommend surgery for patients when that's an option regularly. We do not turn our backs on the standard of care, but we do believe that conventional sort of standard of care therapy is simply part of an effective treatment protocol and not the entirety of it. So standard of care is part of what we need to be doing, but not all of it. And so integrative oncology starts with a true open-mindedness regarding each patient, the unique person they are, and the details of their diagnosis. So in my opinion, the integrative oncologist can best serve the patient by, first of all, thoroughly reviewing their medical records prior to the consultation. It's a big pet peeve of mine when patients go in to see a doctor and they're just flipping open the chart for the first time and trying to read it and figure out what's going on. Taking time before that consultation to really be an expert on that patient really helps a lot. It's all part of being professional. It's respecting the patient's time. It's giving their chart sole focus when there are no other distraction, and that's really important. I also pride myself on getting to know my patient. It's not just about their medical history, although that's important. But I want to know their life story. You know, what are their goals? What are their hopes and dreams? I think that's important. Ordering any diagnostic test that might be helpful. Certainly we need a good biopsy, we need good imaging, but there are also some other tests and things that I found helpful that I like to get on my patients. Discussing all potentially beneficial treatment options from various branches of and philosophies of medicine is also important. And then developing a plan, and that's a plan that's developed in conjunction with the patient. I provide my recommendations, but we make sure that those facets of the treatment plan are in line with the patient goals as well, because we want to help them reach their goals. So we have a large toolbox in integrative oncology. Again, conventional therapies, we talk about chemotherapy, immunotherapy, radiation, surgery, endocrine therapy for hormone-driven cancers like breast and prostate. But alternative therapies can be helpful as well. Mistletoe, we're all familiar with mistletoe during the holidays, kissing under the mistletoe, but it turns out that mistletoe has medicinal properties as well. And so actually infuse mistletoe for all my patients. It helps boost the immune system. It has some anti-cancer properties, found to be a great therapy. Hyperthermia, we use heat. We apply heat to specific areas of the body. That's going to cause some direct damage to tumors. It's going to recruit some immune cells to the area. Actually combine that with chemotherapy. So we heat an area of preference and then we give chemotherapy. Some of the blood's going to be diverted to that area, prioritize the area that's heated. And so we can sort of target the tumor a little bit more with the chemo that's in the bloodstream. Repurposed medications, that's become a hot topic lately. Using medications approved for a specific non-cancer use that we're able to use for cancer because it's been shown in subsequent research to have some really good anti-cancer properties. Metformin is really the most famous example, the diabetes drug. It turns out that metformin kills cancer stem cells. So I frequently will use repurposed medications like that with my patients because it's going to target unique cancer pathways that these other treatments like chemotherapy and radiation therapy do not. And so if we can have as many unique tools at the same time, we can overwhelm cancer. So that's really the goal. Intravenous vitamin C, a lot of people are probably familiar with that. It has some research to support its use against cancer. Sonophotodynamic therapy, we're strategically using ultrasound and infrared wavelengths of light to safely target cancerous areas. So this is just some examples of some of the alternative therapies that I use in my practice. And then nutrition. Nutrition is so important. Anti-cancer nutrition. Certainly I talk a lot about the research on plant-focused diet, fruits, vegetables, beans, nuts and seeds. Those are really our nutritional powerhouses we want to focus on. Fasting is very important. Certainly it's not just what we eat, but when we eat. So fasting is essential, in my opinion, and we need to strategically fast in conjunction with treatment. I have my patients fast leading up to chemotherapy. Each session they fast, so we know it's going to work better when they fast. There is a role for nutritional supplements. I think some people can get carried away, but we know there's certain supplements that can have an anti-cancer effect. Vitamin D is certainly important. There's a lot of research on curcumin, green tea extract, things like that, very important to have as part of the protocol. And then mind-body therapies as well. Prayer and meditation, there's a lot of good research on those affecting treatment outcomes in a positive way. Guided imagery, where we're actually leading patients through exercises to envision their cancer being killed by their immune system, being eliminated, being gone, visualize themselves looking at a imaging report showing no evidence of cancer. These things can actually impact treatment outcomes, and even hypnotherapy for patients who are open to it, going a little bit deeper on the mind-body therapy. Hypnotherapy can be very helpful. So we kind of combine all these things into a unified treatment philosophy, and then of course we personalize that to each patient. And again, there's scientific support for all of these things. Just because it's not part of the standard of care doesn't mean that it's not potentially valuable. So in my office, we don't focus on prognosis. If patients want to talk about it, I will, but patients don't ask me about their prognosis, and I'm okay not talking about it. If patients say they're, down in the dumps over their diagnosis, I usually remind them that all of the research that's developed that statistic was not done on them. Those outcomes did not include them, and that they're unique, and that there are always exceptions, and they need to focus on being one of the exceptions. And so we've seen that happen, and I think it's awesome. I tell patients, focus on doing all you can and rest in that. For my patients who share my religious beliefs, we pray together, we talk about doing our part, but then we also have to just trust God with the rest. We can only do so much. And really, when we think about it, every patient is doing a clinical trial on themselves. So, regardless of whether they're doing an exclusively standard of care regimen, whether they're doing an integrative model or anything else, it's a study of one, an N of one, as we say in the scientific community. It's a study on themselves, and they have to kind of approach it in that way. And I found that's beneficial for patients, that there are no guarantees regardless of what you do. You're doing a clinical study, you just want to make sure it's based on good evidence and good sound recommendations. So in summary, the doctor-patient relationship is sacred. And if you don't have a good relationship with your oncologist or any doctor on your healthcare team, do what you can to improve it. If that relationship is strained and it can't be repaired, find a new doctor. And this is especially true in oncology. There are a lot of oncologists out there. If the one you have just isn't working, find a new one. I mean, this is important. This is not indigestion. This is not sinus problems. This is cancer. And so you deserve to have a really great relationship with your doctor. I think you deserve to love your doctor and have an outstanding relationship with him or her. And the quote I like the most is, the physician should not treat the disease, but the patient who suffers from it. And I think if we keep that central in our thinking, then we're going to have a great doctor-patient relationship. So thank you. I'm happy to take questions. I guess I need to unshare my screen now. But there's some information about me, my practice, my book, my podcast. I have an online cancer course I just came out with. So I'm excited about all these things. And again, I'm just really honored to be here today. So, and I think I unshared my screen, if that's correct. And
all right. Yes, thank you so much. So much of what you talked about in that just resonated with me. I think the approach that I like to take to interacting with other human beings, and just so appreciate hearing your perspective too. So thanks so much for being here.
thank you.
I think we have a couple minutes for some questions, and still to take a break. Our third presentation for today, for those of you participating in the symposium, is shortened. Dr. Lee is not able to join us virtually in person for the conference. And so we have a recorded talk that is a bit abbreviated. So we do have time for a few questions. And I'd like to kick off with one, just to get your thoughts on how technology and the implementation of technology in the face of that's really been expedited or escalated rapidly as a result of the pandemic, just how that impacts relationships, impacts the opportunity to connect, and specifically in this case, the doctor-patient relationship in the setting of cancer. And if you have any thoughts, ideas, or comments on that.
Sure, absolutely. Obviously technology is moving at a rapid pace. We've learned so much and developed so much technology in the last, even 10 years. It's been incredible. I think the thing that stands out to me the most probably is, the human genome, right? We have the Human Genome Project. I believe it was in the 90s when we kind of had mapped the human genome. We have all this information and we don't know what to do with it. And I think in cancer, that's been a big thing because there's all this testing now. Some of the big ones are, Caris and Foundation One and NeoGenomics, those kind of tests. They look for certain mutations and things. And many times you get a report back on a patient and most of the mutations we know they're abnormal. They're mutations to their genetic code, but we don't know what they mean. We don't know what to do with them. We don't have a treatment for them. And so I think one of the problems is we keep saying personalized medicine, let's get all this extra testing on a patient, but then we don't know what to do with the information once we have it. And so I think that's kind of the struggle. The treatment side hasn't quite caught up with the diagnostic and testing side. And so I think that's probably the biggest strain right now. I would say the other big thing is there's this push to find a cure for cancer. I really don't think it's going to be in a pill or one standalone treatment. I think it's going to probably be a cocktail of things, and it's probably going to be different for every patient. Short of being able to actually go change their genetic code somehow, if we can do that, obviously we could do it easily. But I don't think we're there yet. But I think we're getting there. I just think, again, it's the doctor-patient relationship is going to have to be at the core of that to help kind of figure that out as we go.
Great. Thanks so much. Looks like there are a couple questions in the Q&A section. Know if you can see those on your screen. If you want to.
Yes, I'll kind of go in order if that's okay.
Yeah.
The first question, it says, thank you. What's your take on Ayurvedic medicine, the traditional medicine of India? It's interesting. I'm not formally trained in Ayurvedic medicine, but I'm certainly familiar with it. Like when I was doing my research at Harvard, actually, we had a real pioneer in Ayurvedic medicine, not a pioneer, but a real expert from India come over and give a talk about it. That was really my first exposure to the details of the philosophy of Ayurveda. I think it's fascinating. In my mind, at least, I kind of lump that in with other sort of ancient healing practices like traditional Chinese medicine, things that have been around for a really long time. I think they're important. I think there's a lot of value there. And I think, unfortunately, a lot of the research has sort of ignored some of these traditional practices like Ayurvedic medicine. And so I'm a believer in it. I think it has a role to play. And I personally would like to learn more about it. I certainly don't feel like I know enough to implement it with my patients, but I think it's a great thing we need to explore more. It's been around for a long time for a reason, I think. Dr. Renbarger, did you have any thoughts on that? I know these are my questions, but I didn't know if you had any thoughts too.
Yeah, I'm probably in a similar space to you, actually. I know some. I'm very intrigued, interested, open, but it's not something that I practice.
Okay, got it. And then the other question we have, Dr. Stegall, you mentioned confidentiality. If you confide a fleeting thought of depression/hopelessness to your doctor, doesn't it go in your chart? My chart is designed to share medical info among physicians. Where is the guarantee of confidentiality? Wow, that's a really good question. So So there's a line, and it's a pencil line and not it's drawn in pencil and not in pen, if I'm being honest. But there's certain things that have to go in the chart for patient safety. So if there's a concern about a patient harming themselves or being a danger to themselves or someone else, we have to report that. We're legally required to report that. You know, if a patient tells us they're having severe depression, I think that has to go on the chart, just to protect the patient and the doctor. If it's just I've been kind of down lately, I've had a rough week, I don't think that necessarily has to go in there. I think there's a judgment call by the doctor. But you're right. I mean, there are certain things that have to be put in the chart. However, that chart is still supposed to be confidential between the doctor and the patient, and anyone that the patient chooses to share the information with. So if it's something like a my chart, no one should have access to that unless you give it to them. And so I would say that even if something does have to go in there that maybe you wish everybody didn't know, it should only be people that are part of your healthcare team that have access to it. So don't give out your login information would be my advice on that.
Great. Wonderful. Well, thank you so much. It was great to get to meet you virtually after learning about you and getting to know you completely virtually. Great to get to meet you and to hear you talk about a topic that that is so integral to patient care, to cancer patient care, and to really a humanistic approach to medicine. So thanks again.
Well, thank you.
And yeah, and with that, as I mentioned before, we still have to come one more recorded presentation from Dr. Lee, who unfortunately is not able to join us today due to an unexpected emergency. But fortunately is still able to share some of his knowledge and passion with us. It is an abbreviated presentation, and so I believe it's around 25 to 30 minutes. So we do have time for a short bathroom break. It is on my clock, 2:07 Eastern. I think we'll reconvene at 2:15 Eastern for the final presentation. So see y'all in just a few minutes. Thanks. Okay. Welcome back, everybody, for this final session. As I mentioned, Dr. William Lee is not able to join us to present via live virtual presentation today, but we have a recorded presentation. And before we launch into that, I'd like to briefly introduce him. Dr. Lee is an internationally renowned physician, scientist, and author of the New York Times bestseller, Eat to Beat Disease, the new science of how your body can heal itself. His groundbreaking work has led to the development of more than 30 new medical treatments and impacts care for more than 70 diseases, including, in addition to cancer, diabetes, blindness, heart disease, and obesity. His TED Talk, Can We Eat to Starve Cancer, has generated more than 11 million views, and he's appeared on such networks and shows as Good Morning America, CNN, CNBC, and the Dr. Oz Show, and has been featured in USA Today, Time Magazine, The Atlantic, and O Magazine. He's president and medical director of the Angiogenesis Foundation, and is leading research into COVID-19 as well. So with that, we will launch into his pre-recorded presentation.
Hi, it's my pleasure to speak at the 3rd Annual Cancer Wellness Symposium of the Karuna Precision Wellness Center, and I'm going to talk about eating to starve cancer. And let me actually begin by saying that we know that diet and cancer are closely linked together. We know that we eat harmful foods that can actually stimulate inflammation, that's linked to cancer. But the interesting thing is, what are some of the foods that you can eat to actually reduce the risk of cancer, potentially even work together with regular cancer therapy to improve patient outcomes? And that's what I really want to talk about. So let me just share my screen and we will talk about that. All right. We know that the history of cancer is really trying to take aim at being able to send a missile at the cancer cell. And in the beginning, it was chemotherapy, which was not specific, but it did take out the cancer cell. And we used to focus on cancer treatment only looking at the cancer cell, but we now know that it's treating cancer is much more complicated. That cancer doesn't live alone, but cancer cells live in a microenvironment with a lot of other elements. And some of those elements are blood vessels that feed cancer cells, inflammatory cells, that some of them have names like macrophages, and we've got fibroblasts, and there's also immune cells that are present in this tumor environment as well. And so we have an opportunity to affect multiple things within this tumor environment using medications, cancer treatments, and food, diet that can actually help to improve our own body's control over cancer. Now, the idea of food being useful for medical therapy is attributed to Hippocrates, although he didn't actually say this, but in his time, food was medicine because there were no pharmaceuticals and people regarded what they were eating as important for their health. So 2,000 years later, what do we actually have? We have actually insurance companies and state plans looking at the opportunity for foods to serve the role of improving health. We even have advertisements. This is from a billboard, Blue Cross Blue Shield, cancer protection in a bag, fruits and veggies. And we know that that's actually true. We also even have a bipartisan member of Congress working group called the Food is Medicine Working Group, and I've actually spoken at this group. There's interest at the policy level to look at the benefits of food, and there's an upcoming White House conference on food and nutrition and health coming up next week that's also going to be talking about food as medicine, including its effect on inflammation and cancer. Even the Vatican's gotten into it, and I actually spoke there looking at the opportunity of using diet to mobilize our body's health defenses against diseases, including cancer. And these diseases are caused not only by our lifestyle, but our environment as well, which, as we all know, is starting to degrade. So what's the evidence that food can be medicine and why it's effective as a method to intervene with cancer? Well, if you actually take a look on Amazon and look at diet and search for it, there's over 90,000 results. And you've got all kinds of really ridiculous sounding products, Skinny Girl, Lean, 21-day transformation. And it really, really makes it difficult for people to know what is actually evidence-based versus what is just marketing. Look at all these books, Uninflame Me, The Science of Fasting, Beta, 14-day detox. So not surprisingly, there's a lot of confusion out there because of all the products and marketing and advertisement, not to mention just the idea that people want to actually find better health. And it's really difficult to discern what are the benefits. Contrast what you can buy on the internet with what it takes to approve the evidence that's needed to approve a new FDA approved drug, a cancer therapy. The cost is enormous, more than $2.5 billion for a single new drug, including cancer drugs, to be created. And the timeline is extraordinary. It takes more than 10 years actually to create a drug from a discovery of a concept all the way to an improved medicine. Now remember, this is actually how it normally works because, well, we've actually been able to create a mRNA vaccine in less than a year. So one would want to ask, can we actually speed up this process for drug development? And I've been involved with helping to develop cancer drugs. The evidence that we need to get a drug approved is often called an RCT. It's a gold standard. It's a drug intervention where we get to figure out what the improvement of using that intervention is compared to a placebo or a control. And it's all tested under a relatively short period of time, under controlled circumstances. And sometimes these controlled circumstances don't really mimic real life. And it's a yes or no answer. Did the treatment work or did it not work? And we have statistics that try to gauge that. Well, we can't do that quite so simply for food as a medicine. Food's complicated. The benefits of food take place over the course of years, maybe even decades, to be able to actually get the full benefit. And becomes food's not a drug. Food as medicine means we get the benefit of all the substances within food. We actually have to have a different approach, a broader approach to actually accept the evidence. So we do know that you can apply the tools of drug development to look at the evidence. You can look at the genes affected by foods, the molecular steps influenced by foods. You can use lab techniques. They call them in vitro, in vivo, ex vivo. You can use biomarkers to study. These are blood tests to look for markers of how foods influence your blood system, markers in your proteins in your blood. You can design clinical trials and also look more broadly at population-based studies, which is lots and lots of different people to see how food actually influences their outcome. I want to show you something, an experiment, a type of system, a testing system for drugs that I helped to develop at the National Cancer Institute years ago. And on the left side, you see a ring. This is actually the aorta of a lab rat. And you're looking down at it, sort of like an eagle eye. And the white threads that are exploding in a starburst fashion are blood vessels that are growing. And this is how we actually study whether or not we can cut off the blood supply to feeding cancers. So we've actually studied this with drugs, as you've shown here. Cancer drugs are in blue, common drugs like statins and steroids are in yellow. And you can kind of see you look at the top, that black bar at the very top, if you go 100%, that's actually the blood vessels growing out as it would be for a tumor. Now you actually add either the drugs in blue, cancer drugs, or in yellow, and you can kind of see you can knock down those blood vessels to starve a cancer by cutting off its blood supply. This is actually how anti-angiogenic targeted treatments have been developed for FDA approval, of which we've got more than a dozen of them today. Now, what I did with my research group is we've actually studied these drugs head to head with foods, and check out what we actually been able to discover. We've got garlic, we've got soy, we've got grapes, we've got green tea, and this is running the foods head to head against drugs, cancer drugs, and other drugs that are not for cancer, against blood vessels feeding cancers. This is actually one of the most eye-opening experiments that we've actually done. And you can kind of see, you got to take food seriously, the effects of foods, because you can actually compare them to the effect of drugs as well. Here's actually another summary table. I actually showed this at a talk I gave at the Vatican. Tomatoes, fish, coffee, tea, walnuts, soy, fresh dried chili peppers. We actually even know what's inside it. They're called bioactives, natural chemicals. We even know the dose, how much you need to actually give. And we've also been able to measure the outcome. So 2 or more servings of cooked tomatoes a week, about a half cup serving each time, led to a decrease of about a 33% for prostate cancer. Fish with omega-3 fatty acids, 1 to 2 servings a week, 3 ounces. That's about a piece of fish the size of a deck of cards, about 20% reduction in cancer. Kidney cancer for green tea, 3 cups or more a day. And you can kind of see how this is the real serious study of food as medicine that I and other colleagues I work with have been working on. You know the food, you know what's in it, you know the dose, and you know the outcome. So this is not really kind of the hand-wavy stuff you see on the internet. This is real scientific research undertaken by people who are scientists and doctors like myself. But you know, when it comes to food, it's not just about the food, it's about how our body responds to what we put inside it. And if you think of your body as a fortress that's hardwired to protect itself against diseases like cancer, I want to show you this idea of a body fortress. So this is our health defenses. So think about a castle. Your body's a castle. And how are castles defended? Well, you've got the moat, you've got the sloping walls called the talus, you've got arrow slits to shoot out arrows. You've even got something called a murder hole, which is a big hole in the entranceway. You can drop a rock down or boiling oil if there's invaders coming in. Well, our body is also hardwired and defended like a fortress with our own defense systems. And I want to show you what they are. One of the defense systems is angiogenesis, blood vessels. We've got regeneration, stem cells that protect us. We've got our gut microbiome, our gut health. There's DNA protection, and our immune system, which can also protect us by cancer. Now, all of these health defenses are affected by food. And so the area of research that I've been doing as food as medicine is how do we use foods to activate our health defenses to protect us against diseases like cancer. And I want to share with you, starting with angiogenesis, what we've learned. These are blood vessels and normal healthy tissues and organs, liver, lung, heart, nerves. You can see the blood vessels all look different, but if a cancer can hijack these blood vessels to feed themselves. And this is actually how this hijacking works. If you look at the upper left-hand the little black dot here, that's actually a tumor that doesn't have a blood supply. It can't grow because it doesn't have enough oxygen or nutrients. But over the course of months or years, some of the mutations that can occur in a cancer will release proteins. These are natural fertilizers, you can hear in the green bubbles, that actually attract blood vessels to grow from pre-existing blood vessels that can sprout up and start feeding the cancers. And once cancers are being touched by their blood vessels and fed, they can grow 16,000 times in just 2 weeks. So it's a trigger, an explosive growth of cancer. And the same blood vessels that feed cancers allow cancer cells to escape into the circulation as metastases. And many of you will know that the primary cancer, the first cancer, isn't usually the deadly thing. It's really when cancer spreads that the disease really can be difficult to control. So anti-angiogenesis is actually cutting off the blood supply to cancers. And there's a number of drugs that actually can be used to starve cancers. And these are all FDA approved. I've been involved with helping to develop them. And what about food? Remember I showed you this aerial view of the blood vessel looking at from eagle's eye view, and that those little white threads are the blood vessels exploding out. This is what a cancer would try to do to recruit a blood supply. So what happens when you actually drop food into the system? Look at that. You can cut off the blood supply by stopping those blood vessels from growing. And this is actually the effect of soy. This is genistein, which is a natural chemical found in and soybeans. And look at that, it actually cuts off the blood supply directly. Now, some people talk about soy and worry about whether or not soy is dangerous for women with breast cancer because it's a phyto or plant estrogen. Well, I want to show you. On the left is the plant estrogen. On the right is the human estrogen, because some breast cancers are sensitive to human estrogen, and estrogen can make them grow. If you look at the left and you look at the right, you can see they don't look anything alike. All right. And so this is how I do it as a scientist. We look at the data, we look at the chemistry, and actually the plant estrogen not only doesn't look like the human estrogen, it actually blocks human estrogen. So in fact, soy is not dangerous for breast cancer. They're not the same, and they're not dangerous. And here's the proof. This is the study called the Shanghai Breast Cancer Survivor Study. Looked at 5,042 women at the highest risk for breast cancer because they already had breast cancer, and they were young to old, 20 to 75 years old. And they actually take a look at how much soy they ate, and whether or not the amount of soy that these women actually consumed was linked to worse survival for breast cancer. Well, let me just give you the bottom line. Soy intake in women with breast cancer was not associated with increased risk or increased death. In fact, it would lead to a almost 30% decrease in the risk of death from breast cancer. It didn't make it worse, it made it better. And for women who already had surgery and were in remission, the more soy women ate, the lower the risk of the cancer coming back. Okay, this just shows you, and I showed you the chemicals are different. Now, how much soy do you need to eat? Not that much, about 10 grams of soy protein a day. It's about the amount you'd have in a tall glass of soy milk. Now, some people would say, well, you just showed one study, Dr. Lee. There are other studies. What do they actually show? Here's 14 studies stacked up side to side of breast cancer and soy. And check it out. On the left of the dotted line in the middle if you look at the left, is if the soy would actually, the study of soy and breast cancer increased death. And you see nothing there. In every single one of these 14 studies, human studies of women and their soy consumption of breast cancer, in every single case, eating more soy led to better survival. Now, this is really important because this is kind of a proof of concept of food as medicine. Now, what about prostate cancer? Well, and tomatoes. Well, it turns out that tomatoes, I showed you this a bit earlier, have a natural chemical called lycopene. Lycopene is a bioactive, is a carotenoid. It helps to make tomatoes red, and it's actually found in the flesh and in the skin of the tomato. Well, guess what? Lycopene from tomatoes can stop those blood vessels from growing in that same assay I showed you, the aortic ring assay, which is that ring assay, the aerial view, as seen in this paper that was published in the British Journal of Nutrition. And in a large study called the Health Professionals Follow-up Study that involved 46,000 men, this research found that consuming 2 or more servings of cooked tomato sauce a week was associated with the reduced risk of developing prostate cancer by about 30%. I showed you this a little bit earlier. Now I'm actually repeating it again. This was published in the Journal of the National Cancer Institute. And because it didn't actually prevent everybody from getting prostate cancer, some people did develop prostate cancer. They looked at the biopsy tissue from the prostate cancer, and here's what they found. Those men who ate more cooked tomatoes, more tomato sauce per month, had fewer blood vessels actually feeding the prostate cancer, and fewer abnormalities in the blood vessels. And in fact, the prostate cancers were less aggressive as well. Not enough oxygen, not enough nutrition. The cancer can't grow and do as much damage as it otherwise might. Now, turns out that how you cook the tomato actually makes a difference. Now, why do you need to cook the tomatoes? Because lycopene normally is found in a tomato, not that easily bioavailable, absorbed by your stomach and into your bloodstream. But if you cook tomatoes, and the idea is actually to simmer it slowly at 190 degrees Fahrenheit, with a little olive oil, that's basically making a tomato sauce. And what you do is you convert the lycopene into a chemical structure that at 2 minutes, you've actually increased the absorption by 50%. And if you simmer it for a half an hour, so think about your grandmother telling you to slowly simmer, old school cooking of a tomato sauce for 30 minutes, you've increased the absorption of the lycopene. You change the lycopene in a way so that it's absorbed by 250% more. All right, so In this case, cooking doesn't degrade the good stuff, it actually improves its qualities as well. So how you prepare your food is as important as what food you're actually eating. Now, I always ask, what's the best food of any type? So I told you about tomatoes. Well, what's the best tomato for eating if you wanted to fight cancer? This is now being looked at by us and others as well. Which tomato varietals have the highest levels of lycopene? I'm showing you right here. San Marzano tomato from Italy. Cherry tomatoes have a lot. Black tomatoes also have a lot of lycopene, and tangerine tomatoes are already have the lycopene in a preformed state where your body already likes to absorb it from the get-go. So it's not just the food, it's a substance inside it. It's not just the food, it's also how you prepare it. And then within any single food, there's differences in the varietals of food available as well. Food is medicine. You got to ask these kinds of questions. All right, so I showed you foods with anti-angiogenic activity, tomato, soy. Here's a list of other foods with anti-angiogenic activity. And for anybody who actually wants to download lists and get more information about anti-angiogenic foods, come to my website. It's at www.drwilliamlee.com, drwilliamlee.com. Sign up for my newsletter. You can download, get downloads, and I can provide lots of information on these types of foods. And I wrote a book called Eat to Beat Disease. It's available anywhere you can get, buy books. And I have another book coming out soon in the spring. But I've actually summarized a lot of research with tables and charts of all the foods that you might be interested in. What about regeneration, cancer, stem cells, food? Let me show you the idea that our body regenerates. It can't regenerate an arm like a starfish or a leg like a salamander, but after we're injured, our normal healthy stem cells are called into action to repair tissue. This is what happens after you have a cut or a knee scrape or after you have surgery. Our body's health defenses that use stem cells for regeneration are called into action so our own stem cells can rebuild us, regenerate us from the inside out. This is different than getting a stem cell injection into your knee or your ankle or your shoulder. This is actually our own stem cells calling out after injury. And in fact, the greater the degree of injury, the more stem cells come out. And what's really, really interesting is that as we get older, the number and the potency, the vibrancy, the robustness of our stem cells decline. About 50% as is lost as we actually age from our 20s all the way into our 60s and above. And you know, stem cells are important for a lot of different chronic diseases, everything from Alzheimer's to cancer to diabetes to heart disease. But dietary patterns, how we eat, can enhance and help our stem cells regenerate. And there are also dietary patterns that kind of knock out or, gut punch our stem cells. High fat, high salt, high sugar. These things are, we already know, not good for your health. Now we know that they also stun our stem cells. Chocolate is actually, dark chocolate, it's actually good for stem cells. There was a study showing that in adults with heart disease, if you actually had just 2 cups of cocoa a day, hot cocoa, high flavanol, dark chocolate, you could actually double the number of stem cells in your bloodstream. So this is good for repairing your blood vessels, helping to repair your liver, your heart, your brain. But not all stem cells are created equal. Cancers also can create stem cells. In fact, if you had the cancer and you had it treated, if it comes back, it's not coming back, from nowhere. It comes back because baby stem cells of that cancer are present, and they just grow right back. So here's what here's what I'm talking about. You have this initial tumor, you've got cancer treatment, kill off most of the cancer cells, but some of these baby stem cells are around, and over the course of months or years, the tumor recurs because the stem cells grow the cancer back. Now, how can you get rid of cancer stem cells, right? This has been a holy grail in the cancer research world, in the pharmaceutical world, looking at cancer drugs. That doesn't happen yet. We don't actually have a drug that can actually do this, but research has discovered that foods can kill cancer stem cells. This is really a true surprise. The anthocyanin in purple potatoes kills colon cancer stem cells. The proanthocyanidins in dark chocolate kills breast cancer stem cells. Extra virgin olive oil, hydroxytyrosine, kills prostate cancer stem cells. There's rosmarinic acid in thyme that kills prostate cancer stem cells. Capers actually have chlorogenic acid and quercetin that kill prostate cancer. Walnuts actually have dietary fiber that activate your gut microbiome, boosts your immunity, and it also has bioactives that kill colon cancer stem cells. And green tea kills stem cells from colon cancer and breast cancer stem cells. So Mother Nature's much more clever than we can do in a pharmaceutical sense. She's already created foods that can actually have that ability to kill cancer stem cells. So this is, again, after you've had cancer, treated cancer, you don't want it to come back. This is another application of food as medicine in the context of cancer treatment. Let me just wrap up by talking about your two other health defense systems, your microbiome, gut health, gut bacteria, and your immune system, because they're linked together. Now, in 2018, 4 years ago, the Nobel Prize was given to two researchers, Dr. Jim Allison, who I know, and Dr. Tasuko Honjo. They actually discovered the principles by which you can activate your immune system to kill cancer stem cells. This is a huge breakthrough because it's benefiting people around the world. One of the first most prominent beneficiaries of immunotherapy, cancer immunotherapy. By the way, cancer immunotherapy doesn't kill cancers by poisoning like chemotherapy. It actually doesn't even attack the cancer cells directly. Immunotherapy activates your own body's immune system so that your own body does what it naturally wants to do, which is to go after and knock out cancer cells. One of the first recipients that actually benefited is our former president, Jimmy Carter. He had melanoma spread to his liver and his brain. And, at the time, there was not much more that could be done. So President Carter actually wrote his own obituary and said, "I'm at peace with myself, ready to meet my maker," right? But then at the last minute, he got immunotherapy. And the immunotherapy was given actually was able to wipe out even melanoma that had spread to the brain. So although this is in President Carter's images, this is the kind of thing that happened to him. On the left before treatment is a melanoma that spread to the brain. You can see in the red circle. After immunotherapy, activating your own immune system, no chemo, your own immune system goes into your brain and actually wipes out the cancer. Quite remarkable. All right, and this is happening for lung cancer, kidney cancer, endometrial cancer, all types of cancer by activating your immune system really to take out the cancer. It's one of the most natural things you can do. Now, cholangiocarcinoma is gallbladder cancer. It's actually very, very deadly. And they've also used immunotherapy to wipe that out. Look at these images. On the top is a CT scan. And you can kind of see in the bullseye there, and with a yellow line pointing to that dark, ominous black spot, that's the cancer. And actually, after using a little radiation and immunotherapy to activate it, look at how small that cancer has shrunk using the immune system, by activating the immune system. And you can kind of see on the scan on the lower right, I can barely see it at all. So this is actually taking a very, very universally deadly cancer and activating it with the immune system. All right. Now, it turns out your immune system actually talks to your bacteria, your gut microbiome. And this is actually important as well, because not only do you give immunotherapy, you can also give probiotics to really help to activate your gut bacteria. And this is actually from a study from my colleague, Dr. Laurence Zitvogel, who actually showed that using immunotherapy, the same kind of treatments that Jimmy Carter had, if you had the right makeup in your gut microbiome, you're more likely to respond and survive your disease. And this is what she found, is that the gut microbiome, there's one bacteria that seems to be very important to help your body respond to immunotherapy. And that bacteria is called Akkermansia muciniphila. And you can't really eat that probiotic right now. However, you can actually eat foods like pomegranate, like cranberries, that help your gut secrete mucus that this Akkermansia healthy gut bacteria likes to grow in, right? So here's how it works. The pomegranate, for example, makes more gut mucus. The Akkermansia loves to grow in that mucus. You're making it really, really a favorable environment to grow. It's like putting fertilizer out there. So your seeds really love to grow. And this Akkermansia releases substances that actually activate your immune system. So all of your immune systems get lit up. Now, when you give immunotherapy, and this is a bag of immunotherapy hanging that actually you need your immune cells to respond to, you've got Akkermansia pumping these guys out. This is actually a way you can combine not food versus medicine, but food and medicine, cutting edge medicine, and cutting edge knowledge of food as medicine to make the immunotherapy work better. Now, this bag I'm actually showing you because this bag was actually hung for my mother, who was a cancer patient with endometrial cancer. And what we actually did is treat her with an immunotherapy. We gave her pomegranate juice and cranberry juice. She grew Akkermansia, and she was a complete responder. 3 treatments, no chemo, a little bit of radiation, and all of the cancer in her body disappeared. Now, we know that actually you can use food to activate your immune system from other studies as well. This is actually a timely study. We're getting towards fall. People actually are likely to get the flu. So you get a flu vaccine. Now, turns out that if you eat foods like broccoli sprouts that have a natural chemical called sulforaphanes, you can activate your immune system that will make you respond better to the flu vaccine. So this is a study from University of North Carolina, Children's Hospital in Basel, and Stanford University. They enrolled 29 healthy volunteers, young people, and they gave them all the flu vaccine through the nose. And then they gave half of the group 2 cups of broccoli sprouts to have in a shake every day for 4 days. And then what they did is they measured how much immune response was in the bloodstream after giving the flu vaccine. And the sprout eaters compared to the non-sprout eaters, everybody got the vaccine, 22 times higher natural killer T cell immune response. So the broccoli sprout propped up and amplified the immune system by 22 times in the natural killer cells. And those natural killer cells had more killing power against the virus. And people, when they actually swabbed the nose, the people who ate the sprouts had fewer virus particles in their nose. So this isn't about cancer. This is about using food to activate your immune system. But I showed you earlier, you can activate your immune system to go after cancer cells. So it's really, really exciting that not only are we saying food has the properties of medicine, but you can combine food and medicine together. And that's really important for patients. Now, what's in broccoli? Broccoli and broccoli sprouts have a substance called sulforaphane. And this has actually been shown against deadly cancers like cholangiocarcinoma, the gallbladder cancer, again. And in fact, people have studied that the more fruits and vegetables you eat, the lower the risk you have of developing cholangiocarcinoma. And this is the fruits and vegetable intake seems to make a big difference. And if you actually take a look at gallbladder cancer and look at dietary, there's even clinical trials looking at food as medicine in the clinical trial database of the government called clinicaltrials.gov. All right. So, and these are all being done internationally in Warsaw, Poland, Montreal, lots of interesting places. Now, I told you about genistein, the phytoestrogen, told you about lycopene in tomatoes. I just told you about sulforaphanes in broccoli. And this is actually the work of the research. We're actually trying to pin down what are in foods that actually can have health defense boosting and cancer killing effects or immune boosting effects to go after the cancer. And here's a bit of a glimpse at the future of what we're actually doing. There's something called the flavorome. And this is really, what are the substances in food that create the good flavors and how do they actually interact with your body to activate your body's health defenses, including fighting cancer. This is just as a little glimpse of the future for you. People are working on this flavorome. You've heard of the human genome? Well, in the future, you're going to be hearing about the flavorome. What are the components of the plants that are actually useful as well? So, for cancer, we think about going to the hospital, going to the infusion unit and the pharmacists, work with the doctors and the oncologists to pull down drugs and give us infusions or take pills. That's always still going to be important for treating cancer. Immunotherapy, as I showed you, is like Jimmy Carter and my mother, really, really dramatic advances in the treatment of cancer. But between trips to the infusion center, between doses of chemo drugs that might be pills, There is another type of chemotherapy or medicine you can take 3 times a day, and that's the diet that you eat. And I hope I've shown you some of the evidence that researchers are doing to show that in foods, Mother Nature has actually loaded foods as part of a natural pharmacy, not pharmacy with a PH, but pharmacy with an F. Things that we grow have natural chemicals that can have profound effects to boost our defenses against cancer. So I'll just close with this quote from the Nobel laureate Albert Szent-Györgyi, who once said that discovery consists of seeing what everyone has seen and thinking what nobody's thought. And I hope what I've shown you with in the past hour actually gives you a little bit of a sense that our food is not just tasty, not just delicious, and not just nutritious and gives us the energy that we need to survive, but actually a powerhouse of natural chemicals that can boost our body's defenses and boost and have very powerful ways to be able to tackle cancer. And with that, I thank you very much.
All right. So that I hope I share other people's sentiments in saying that was really engaging and a wonderful talk. The one thing I would add to that, which may be an update that Dr. Lee was not aware of, but Acromancy is actually available as a marketed or available probiotic through a LifeOmic partner called Pendulum. I actually take it. My teenagers also take it. And so if anybody wants more information on that, I'd be happy to share that with you. And with that, I want to thank everybody for participating today. I apologize again that Dr. Lee is not available for questions live today. I know that he's happy to help in fielding questions and answering questions that have come up. Feel free to reach out to us. I will put my email in the chat here. So feel free to reach out if anybody has questions, would like to have additional follow-up conversation. You will be receiving a survey for feedback, questions, comments. We welcome any thoughts or ideas anyone has. And with that, thank you so much and have a great rest of your week.